আগে ইয়াটা দেন ইন্ডেক্সটা দেন এটা থাকো Okay, hello everybody. Welcome to the second session on cardiology. This is Dr. Jannat Akter Riva. I extremely apologize on behalf of the entire team for being a little bit late. Today we have had like a student protest going on, which is why multiple roads in Dhaka is actually congested, which is why I wasn't able to arrive here on due time. However, moving on, as we have already I am pretty sure that most of you have been waiting so far. So I will just go straight to the discussion points. However, just a short introduction because we have like two to three new students who will be joining us today. So I welcome you all from the international panel, Dr. Antarikya Bordoloi and Dr. Clement Lee, and from the national panel, Dr. Shoma, right? So, okay, I welcome you all to the first class. Hopefully you will be able to get the first class on the cardiology, which was conducted earlier in the previous week. It will be available on the e-learning platform. So don't worry about that. In my previous class, we have basically gone through the ischemic heart disease, and we have also gone through like heart failure and the management of heart failure, different classification of heart failure. And then I briefly discussed about some of the peri-arrest cardiac arrhythmia situation and how to manage them on an acute emergency basis. So even if you're worried that arrhythmia portion was not covered properly, don't worry about that because in this class, I will go through the bit of basics about the cardiology and also discuss about the arrhythmia only. So that will be our today's discussion points. In the third class, we will go through the valvular heart disease and the congenital heart disease, as well as interpretation of the cardiac catheterization test. And in the final class, we will go through systemic and pulmonary hypertension, cardiomyopathy, and the rest of the topics, which are, which are important for cardiology from different perspectives, which will be discussed in the final class. So today's class, we will mainly cover through the primary concepts of cardiology, especially the ECG, heart sound, and JVP and pulses, different types of pulse heart sounds. These information, and the second portion will be solely focusing on the cardiac arrhythmia. That will be the today's discussion topic. Before I proceed, so there will be cardiology is considered to be one of the major topics for MRCP Part 1 examination, which is why you can expect around 15 to 18 questions coming. I know that in the Part 1 website, MRCP official website, it's written that 15 questions will come from the cardiology, but sometimes some basic medical science cardiology perspective question, for example, from physiology perspective or from pharmacology perspective, further additional questions can come. So if you count them together, then the question range will be usually 15 to 18 questions coming from cardiology solely, which will be scattered in the two groups of Part 1 examination. So whoever, if you're joining us newly, just a brief introduction about the Part 1. This is basically two papers are in there. So paper A and paper B, and you'll get 30 to 45 minutes of break in between these two papers. Each of this paper will be consisting of 100 questions. So there will be 200 questions. These questions are basically single best answer type of MCQ questions. And from the major system, usually 15 questions come. And most of the questions will be, that is 25 questions will come from the basic clinical science portion, including statistics and epidemiology. And from the minor systems or the subspecialties, you can expect around 5 to 7 questions. For example, psychiatry or maybe geriatric medicine or acute medicine, all these subspecialties. So, all right, we will move to the first portion. So before going through ECG, this is the picture of cardiac action potential. As you can see, 0 is actually this entire upstroke. And then the resting membrane potential RMP, this is the within the basement membrane. That's when the action potential is basically 0. So that's the fourth stage. And number 1 is basically the first downward deflection. Okay, and then this is the plateau phase or the second phase. And finally, this is the late repolarization, or this is the last downward deflection here. So the main importance of cardiac action potential and how it is different from the rest of the action potential is because of this plateau phase. Because in other muscle fibers, the action potential, they do not have this type of plateau phase. So we know that usually in the cell membrane, what happens, the sodium gets influxed and the potassium gets outside. 3 sodium and 2 potassium. That's the basic physiology. And here, this sodium influx is causing the rapid repolarization or the upstroke here. And the first early repolarization, this is depolarization phase and this is repolarization phase. In the repolarization phase, the potassium is getting out, but not all of it. And in the plateau phase is because of the calcium channel where there is slow influx of the calcium, which causes a sustained contraction within the cardiac muscle. So that's why you will see the cardiac muscle remains contracted for 10 to 15 seconds longer than the rest of the muscle fibers, which actually helps in sustained pumping of the blood throughout the whole body. So that's why this is the importance of the plateau phase. And the final, the late repolarization or the final downstroke is the stage 3 or the step 3, which occurs due to rest of the potassium getting effluxed or outside of the cell. And finally, 4th phase is basically going back to the initial phase, that is the resting membrane potential, so that another action potential can start place with the rapid depolarization phase. So this is all, put together in the box. Just give it a read. Sometimes they can give you like true, false related question or correct, incorrect related questions from this type, like phase 0 is indicative of late depolarization. So that's a false statement. And plateau is because of fast-acting potassium influx. So that's actually false because even though plateau phase is due to the calcium influx, but this is not fast-acting. This is slow-acting calcium influx. So that's why they might give you some, true, false related statements coming from this box. Now, we know that the electrical conduction system of the heart starts from the SA node, then goes the AV node, then the branch, and then AV node branches, like the left and the right branches, and then you have the Purkinje fibers, right? So if you see, like the most important information from here would be in the ventricular conduction is conducted with the help of Purkinje fibers. And the velocity is the most in comparison to the other conduction pathways. So that's why in the ventricular conduction, it actually allows for, we know that most of the blood is accumulated or accommodated within the ventricles, and ventricles are the main chambers which helps in, pumping out of the blood. So if you consider the cardiac output, of course, every chamber has their, contribution in here, but cardiac output is mainly left ventricular ejection fraction dependent, okay? So that's why ventricles are always putting more contribution towards forming an entire cardiac output. So ventricular conduction needs to be more rapidly happening. The electrical conductivity within the ventricular system needs to be more rapid in comparison to the other parts of the heart. That's why in the Purkinje fiber, you'll see that the velocity rate is more in comparison to the other conduction pathways. This allows a rapid and coordinated contraction of the ventricles. Ultimately, everything in your body, the normal physiology, will be helping for the effective cardiac pumping. That's it. So here you can see in the question number 1, which of the following is responsible for plateau phase of the myocardial action potential? I think you will all be able to get it right. The answer is, anyone? Slow calcium influx. So slow influx of the calcium. So here you can see there is also mention of slow calcium. This is also slow calcium. But if you're not careful, then you might easily just, give option A, which is a false answer. Option D is the correct answer. So this is just a regular question. Again, it might be present for some true false statement related question, like sometimes in the ECG changes, not everything is actually pathological. For example, in female patients, we see lots of, especially in the chest lead, in the V1 and V2 chest lead, we see the ST elevation or T wave inversion. So these are actually within normal variant because there is no successive changes in the other leads. So that's why we have to, and the patient is not symptomatic. Because of, female breast, the way the electricity passes, it can cause some changes in the ECG. So that's why in obese patients as well, in very extremely thin patients or, in extreme of ages, for example, in babies or more than, less than 15 years of ages, the entire cardiac axis is not, like that of an adult. So that's why sometimes some ECG variants can be present, but those are considered to be within normal if the patient is not having any structural heart disease and the patient is not having any symptom. For example, sinus bradycardia commonly seen among the athletes or people who are exercising regularly. Junctional rhythm can be occasionally seen in some individuals. First degree heart block, but it will not be present in the successive leads, okay? And Wenckebach phenomenon. So these are all some, like normal variants of ECG. However, left bundle branch block is always, even though right bundle branch block can be considered sometimes within normal variant, left bundle, remember, left bundle branch block or LBBB is always pathological. All right. Now, in terms of the coronary arteries, you can see that which ECG leads will be indicative of which area. This is mainly important for, like ischemic heart disease, and particularly important for going for, like stenting or, angiogram process. So in the chest lead, for example, from V1 to V6, we know that this is basically anteroseptal or extensive anterior. So all the chest leads will be, involving in the presence of an extensive anterior myocardial infarction. So ECG changes will be evident. ST elevation will be taking place in all of the chest lead. Similarly, inferior leads are basically represented by limb lead 2, 3, and AVF. And inferior surface of the heart is mainly supplied by the right coronary artery. Just there was this flow diagram that I made earlier. This is basically the very normal and very simplified version of, like right atrium, right ventricle, left atrium, left ventricle. This is the mitral valve. This is the tricuspid valve. And from the right ventricle arises the pulmonary trunk, which is divided into right and left pulmonary arteries going into two sets of lungs, okay? And then, this from the left ventricle arises the arch of aorta. So basically, this is the ascending aorta, and then you have the arch of aorta and the descending aorta, which is divided into the thoracic and the abdominal aorta, blah, blah, blah. And basically responsible. So right ventricle will be responsible for pulmonary circulation mainly, and left side of the heart is mainly involved with systemic circulation in generally. So when the arch, so basically when the aorta arises, in the aortic valve, you will see that there are a couple of cusps that are present. So there are 3 cusps present, or the sinuses. So one is a non-dominant and the other one is the right and left coronary sinus. Sorry, right and left coronary sinus. So from the left coronary sinus arises the left coronary artery, and from the right coronary sinus, these sinuses are also known as dominant and non-dominant coronary sinus, okay? From the non-dominant coronary sinus, usually no coronary artery arises. That's why this is called non-dominant. And from the dominant coronary sinuses, this is divided into right and left, and each of the right and left coronary sinus arises right and left coronary artery. So from the right coronary sinus arises the right coronary artery. Right coronary artery actually is responsible for, so left is further, divided into, for example, from here, this goes as the left coronary artery goes along like this particular area, supplies the major portion of the ventricular surface of the heart as well as the apex of the heart as the left anterior descending artery. And there is a rotating branch like just around the atrioventricular groove. Left side of the atrioventricular groove is the LCX artery, or also known as the left circumflex artery. And the right coronary artery actually goes behind the heart, okay? And mainly posterior surface, base of the heart, and the inferior surface of the heart, these are supplied by the RCA, which is gives the continuation branch of the right. So you don't have to know about the details, just remember that RCA, basically base of the heart, inferior surface, and posterior portion, posterior aspect of the heart. These are actually supplied by the right coronary artery. And also among the electrical active like conduction pathway, the SA node in 60% of the individual is supplied by, since the SA node is very much close proximity to the base of the heart, so in 60% patients this is supplied by the RCA. All right, now let's go. So for example, in patients who are having like V1 to V4, this is known as anterior V or anteroseptal leads. V1 to V6, this is known as extensive anterior. So these are all problems happening in the LCA. And then lead 2, 3, and AVF, these are all indicative of inferior surface of the heart. And this is indicative of RCA territory or right coronary artery territory. All right. Now, there are some other areas of the heart as well. For example, lateral aspect is represented by lead 1 and AVL mainly. Sometimes V5, V6, or that can be also represented by the lateral leads. So this lateral portion of the heart is mainly, it actually has dual supply, but mainly then again LCX or LCA artery, basically. Here you can see the lateral portion is left circumflex. And posterior, how we can understand, like we don't have the chest leads only capture the electrical activity from the front of the chest, right? So how do we understand that which posterior area is infarcted or there is ischemic changes within the posterior surface of the heart? You can see that in the V1 and V2, there will be very tall R wave. So that is indicative of left circumflex artery. Sometimes it can be partially supplied by the right coronary artery as well. So just take a look at the, I think a Google picture will be more helpful. Coronary circulation. I think this one is the most simplified photo that you can see. So this is basically, this is the right coronary artery, okay? You can see, and this is the left coronary artery. So the right coronary artery is responsible for base of the heart, inferior and some posterior aspect of the heart. Like this is basically the branch of the right coronary artery. And this is the left main artery, which is bifurcated into two major arteries. This is the left circumflex artery, which goes like this along the atrioventricular groove. And this is basically the left anterior descending artery, which is the continuation from the left coronary artery. And you don't really have to know about the marginal artery or anything because this is the basic anatomy that you will need for MRCP part 1. So let's solve some question. So 62-year-old patient comes to the emergency department with a 25-minute history of crushing central chest pain. ECG shows ST elevation in the leads 1 and lead AVL. So which territory is likely to be affected? The answer is lateral, because lead 1 and lead AVL is represented by the lateral, representative of the lateral surface of the heart. And they can give like questions from this particular box, like which artery, which leads is representative, in which leads you can expect ST elevation in, or they might change the question like there are changes in this particular lead. So what surface of the heart or which area of the heart do you think is affected, or which artery is involved in here? So in the previous question, you can see it was about all about the which coronary territory is likely to be affected. But now they're asking direct questions like which coronary artery is likely to be affected. So question is, 83-year-old man presents with ischemic sounding chest pain. So what they meant is like cardiac chest pain and persisted for the past 1 hour. In 12-lead ECG performed shows deep T-wave inversion in lead V1 and V2. So deep T1 inversion, that is within the anterior leads. So which is the most likely implicated coronary artery? So this one is a little bit tricky because it can be both, I think, both. Anyone who can give the answer? Deep T-wave inversion in lead V1 and V2. What will be the answer?
Answer is C. Proximal left anterior descending artery.
Okay, so which territory is indicative? V1 and V2, what does it indicate? This is not actually entire anterior portion, okay? This is partial, actually, partial anteroseptal portion is affected. So very good. You give the right answer. That is proximal left anterior descending artery, because in the earlier diagram you can see. So this only this portion of the heart, this portion of the coronary artery might have been affected, which is reflected by deep T-wave inversion or ST changes in lead V1 and V2. Not always like anterior MI or anterior septal MI, the changes will be from, like successive V1 to V6. It will not be like that. Sometimes it can be involving just the V1 to V3, those leads only. Okay. So axis deviation, the simple way to remember which axis deviation is due to what causes. Usually I used to remember like most of the right heart pathology is due to some sort of pulmonary problem, and left heart pathology is usually due to some coronary or heart problem. So you can also remember it like this. As you can see, the causes of right axis deviation is due to right ventricular hypertrophy, left posterior hemiblock, because the posterior artery is on the behind or towards the right side. That's why left posterior hemiblock can cause right axis deviation, but the left anterior hemiblock will cause left axis deviation, which is just because of the anatomical position. That's it. Chronic lung disease, again, pulmonary pathology, pulmonary embolism, and ostium, secondum ASD. Then it can also be considered in normal, particularly in infants or in very tall people. And WP syndrome, I think this one is the most important one, because they can, rotate the answer. Like WP syndrome can cause both right axis and left axis deviation. But if the accessory pathway is on the left side, in that case, it causes right axis deviation. But if the accessory pathway is on the right side, it causes left axis deviation. So for WPW only, the accessory pathway will cause actually different or opposite type of axis deviation. Sorry. Two easily complicated true-false statement for right axis and left axis deviation is hemiblock and WPW, basically. Because I know that ultimately you will be able to figure out that lung pathologies are causing right axis deviation and cardiac pathologies will be causing left axis deviation. That's like very normal. But you will actually mess up, like WP syndrome can cause both right and left axis deviation, but which is which? You can remember it like the right accessory pathway will cause left axis deviation, and left accessory pathway which will cause right axis deviation. So for WPW, it's left and right, right to left, like vice versa. And for hemiblock actually, like if you remember, this is SA, AV node, and then basically these are Purkinje fibers, and this is anterior and this is posterior. So posterior, you can see this is actually more in inclination towards the right side. So that's why the left posterior hemiblock will cause right axis deviation, and left anterior hemiblock will cause left axis deviation. So they have also given some, like mnemonics here. So in question, Wolff-Parkinson-White syndrome is usually associated with most of the time left axis deviation, because the right accessory pathway is actually a more common variant for the WPWB syndrome. So you can see which each of the following is associated with a left axis deviation, except for the answer is left posterior hemiblock, because that causes right axis deviation. So now can anybody give me the answer for question number 8? Each of the following is associated with a right axis deviation on the ECG, except for
C.
Option C. Yes, very good. Because in WPW, right actually causes left axis deviation. All right. So PR interval, again, just go through the cause. This is actually what are the causes of the first degree heart block or prolongation of the PR interval. Most of the time, it will be due to some cardiac causes. Either it can be due to some idiopathic cause or could be due to ischemic heart disease, could be due to digoxin toxicity, cardiomyopathy, and all this thing. Important causes would be aortic root pathology, okay? Aortic root pathology and rheumatic fever. It's actually within one of the minor criteria for I'm not sure if you remember it from your medical undergraduation level. So there are like major minor criteria for rheumatic fever, right? So prolongation of the PR interval was within a Jones criteria or modified Jones criteria for rheumatic fever. I will cover this in the next, in the third class. So rheumatic fever, hypokalemia, and aortic root pathologies, these are actually more important causes for prolongation of the PR interval. Short PR interval is actually seen in WPWP syndrome and hyperkalemia can rarely cause a prolonged PR interval, but this is much less common association than hypokalemia. Basically, for short PR interval, only one cause you have to remember, that is WPWP syndrome. All right. This is, you can see, diagnosed with endocarditis of the aortic valve. He's treated with IV benzyl penicillin and gentamicin. What is the most important ECG changes to monitor for? So aortic valve pathology, what will it cause? Prolongation of the PR interval. Again, in question number 10, you can see which of the following is the least associated with the prolongation of PR interval. The answer is hypocalcemia, because hypokalemia can cause prolongation of the PR interval. Hypocalcemia, on the other hand, it usually causes long QT syndrome, not prolongation of the PR interval. So hypocalcemia here is the answer. Now, a complete heart block. So complete heart block, normally ECG, what is the ECG changes? This is also an undergrad level question. Number one is bradycardia. So this is a regular bradycardia. This is the commonest finding. So if you, in the ECG, you see that the heart rate is less than 50 per minute, then it can be either due to sinus bradycardia or it could be due to complete heart block. So these two things you have to always exclude in a patient with bradycardia, okay? So number two is in the ECG, the PP interval will be regular and RR interval will also be regular, but PR interval is actually irregular, or basically PR interval will be variable. And not all P wave is followed by a QRS complex. So that is indicative of atrioventricular dissociation. So now let's go back to the, I hope there is a ECG here. No, okay. I think this picture is quite, you can see like visibly, this is indicative of bradycardia. And if I zoom this picture, you can see that this P and P interval and this P and P interval and this P and P interval, these are all regular. So there is like approximately like two large, like blocks and 2, 2, 4. So 10, 11, 12, 13. So approximately 13 small square in between each of these PP intervals. So it is quite regular, you can see. You can also like use a scale, like a measuring scale to calculate the exact distance. And each of this RR interval, you can see these are all regular. But the P and R intervals, and from this P and R intervals are not regular. And this P wave is not followed by a QRS complex. Not all P wave is followed by a QRS complex. So that is an ECG of complete heart block should look like. So what are the features of complete heart block? Most of the patients will complain of either palpitation or syncope. Syncope is the commonest presentation of complete heart block. And patients might eventually be presented with features of heart failure because of this, like regular AV dissociation. Of course, the net effect or the cardiac output of the heart will not be adequate enough to pump the blood throughout the body. So that's why patient, like towards the long run will be presented with heart failure. Regular bradycardia, again, it will cause syncope and palpitation. And in the pulse, you can get bradycardia. In the blood pressure, if you measure, then the difference between the systolic and the diastolic blood pressure will be huge. So there will be a wide pulse pressure. In JVP examination, actually, JVP examination, after passing paces, you will be, JVP, I understand that not all of you are very much, how do I say, comfortable with, because we can examine the pulse, we can listen to the heart sounds, and in clinical examination, we routinely check the, auscultate the lungs, we routinely check the abdomen, we routinely check the legs and everything. But for some reason, JVP is not something that we commonly examine. And as it's a complicated process, like by bedside examination, JVP examination requires lots of, dedication. You have to be, two physicians should be present, and you have to measure the JVP, like use two different type of scales in order to measure the JVP, match the height, and then match the height of the JVP with the, water pressure. So that's why measuring JVP is quite, difficult. However, don't worry, after passing PACES examination, it will be quite within your grip. So if you examine the JVP in a complete heart block patient, the A wave, I think they have missed the information here. It will be Canon A wave in the neck. In JVP, this is a diacrotic pulse, right? So there are two peaks in comparison to the carotid pulse. Carotid pulse usually has an upstroke and a downstroke, and there is only a single peak. But in case of a JVP, this is a diacrotic pulse. So there is two peak and two descents. I will also come back to JVP a bit later. So A wave is the first, peak of the pulse. So that will be Canon A wave. It's actually produced due to atrial contraction against a closed tricuspid valve. And the first heart sound is variable intensity. Why? You can ask me why this is a variable intensity of first heart sound, because we know that first heart sound is produced by closure of the mitral and the tricuspid valve, right? In case of a complete heart block, the problem is actually like there is AV, atrioventricular dissociation. So because of this dissociation changes, before the valves are closed, the atrium is contracted. So as a result, it will actually cause the first heart sound will be variable each time. So that's why you will get the variable intensity of the first heart sound. So in terms of heart block, there are actually three different types of heart block: the first degree, second degree, and third degree. In first degree heart block, the PR interval is actually prolonged. So that is more than 1 small square or more than 0.2 second. That is prolonged PR interval. And second degree heart block is further of two type. Always remember that Mobitz type 2 is actually a bad heart block. It can go anywhere, like anytime, it can progress into complete heart block. But first and second degree heart block, or the type 1, Mobitz type 1 heart block, this can be sometimes, if you find out the cause and treat, that can be okay. Or it can be sometimes within normal variant as well. As we have previously discussed, like Wenck-Quebec phenomenon, junction rhythm, regular bradycardia, prolonged PR interval, this can also be considered within normal variants of ECG. But left bundle branch block, Mobitz type 2 heart block, complete heart block, these are never physiological. They are always pathological. Okay. Second degree heart block, Mobitz type 1, also known as Wenck-Quebec, this is basically progressive prolongation. So this PR interval is static. First degree heart block is always static, but in successive leads, you will see that the PR interval is actually gradually more prolonged until a drop beat occurs. That is type 1. And in type 2, PR interval is constant, but the P wave is not often followed by a QRS complex. So almost very much similar to the third degree heart block. And third degree heart block, as I have already mentioned, that there is no association between the P wave and the QRS complex. So that is atrioventricular dissociation. Let's try to solve question number 11. A 72-year-old male is admitted to the emergency room following a collapse at church. ECG reveals dissociation between the P and the QRS complex with a rate of 40 per minute. So that's bradycardia, and there is AV dissociation. Patient is 72 years of age, presented with syncope. So the diagnosis is basically complete heart block. Which of the following clinical findings may also be found? So they want to know what clinical parameters you can get in a complete heart block patient. So is it loudest one, which is not true because the first sound will be variable intensity. Loudest one is a physical feature of mitral stenosis. Narrow pulse pressure, that is also false because we would be expecting a wide pulse pressure. Giant V waveform in the JVP, that is also false because we would be expecting a Canon A wave in the JVP. Variable intensity of the first heart sound. This is the true or correct answer. Okay. All right, now we will discuss about, and remember that one of the most common causes of complete heart block, actually, I think that might have been missed. Number one for complete heart block is degenerative disease. Especially if with progressive, like ages, there might be calcification and calcifying plaques depositing within the conduction pathway of the heart. So degenerative disease is actually one of the number one common cause for complete heart block. Number two would be myocardial infarction, or particularly inferior MI that can lead to complete heart block. Number three is sick sinus syndrome, which is a common type of degenerative disease seen among elderly patients, sick sinus syndrome. And some drugs, like, for example, calcium channel blocker, beta blocker, digoxin. So these rate controlling agents, if there is toxicity of these medications, it can lead to complete heart block. And during surgical procedure, like, for example, in EPS study or for, like ASD-VSD closer, if there is a surgical trauma to the SA or the AV node, that can lead to, complete heart block. So these are basically some of the common causes of complete heart block. All right. Now we will discuss about the left bundle branch block. So good thing is you don't have to go through extensively through the left bundle branch block because trust me, Garbosa and modified Garbosa criteria for diagnosing left bundle branch block and whether this is associated with MI, that is very, very difficult. Even I am still like not 100% comfortable with using modified Garbosa criteria. But for MRCP purpose, particularly for part 1 and part 2, all you need to know that you have to learn the stem and you have to know the primary changes of the ECG that is indicative of the left bundle branch block. So in order to, remember that which is indicative of left bundle or which is indicative of right bundle branch block, this William Marrow actually will help you. So how it will help you, I will also write it down. So the mnemonic William Marrow. You'll notice that I'm writing a couple of words in capital letter like W, L, L, and M. These are all within capital letter. So we will look at V1 and V6. So for this is left bundle branch block or LBBB. So in V1, there will be a W pattern like this, okay? So this is in V1, there is a W pattern, and in V6, there is an M pattern. So that is left bundle branch block. For right bundle branch block, in the V1, you will see the M pattern. And in the V6, you will see the W pattern, okay? So that is for right bundle branch block, an easy way to know like right bundle versus left bundle branch block. So causes of left bundle branch block, you will see always most commonly due to some heart causes or cardiac abnormalities, mainly ischemic heart disease, hypertension, cardiomyopathy, aortic stenosis, and so on. New left bundle branch block is always pathological and may be a sign of myocardial infarction. Diagnosing a myocardial infarction for patients with existing LBBB. So in a patient who already has LBBB and now whether the patient has a new MI or not, that can be quite difficult. So that's why the Garbosa criteria will actually help. Which fortunately you don't have to learn. Each of the following may cause, okay, not this one. Okay, we will go to the ST elevation. So commonly without seeing the, like in this book, let me know what are the common causes of ST elevation that you can think of. First one will be ST elevated MI, right? Because this is the most common cause of ST elevation. Number two, one of the complication related to MI, that is left ventricular aneurysm. And that can be particularly detected if a patient who have sustained an MI and in the successive ECG, even after receiving thrombolysis or like myocardial reperfusion strategies, even after going for, or maybe you have given the patient stenting even, but after that the patient complains of pain, and in ECG you see that there is still ST elevation. That is very much indicative of left ventricular aneurysm. Number three is pericarditis. Normally in in ST elevation, we know that the convexity is upwards. And in case of a pericarditis, the ST elevation is usually concavity upwards, okay? All right. So these three are the most common causes of ST elevation. So can anyone tell me some non-cardiac causes for ST elevation? This is seen in head injury patient, okay? Head injury patient, intracranial hemorrhage, especially in subarachnoid hemorrhage. Sometimes ST elevation, even T-wave inversion can take place. Normally, T-wave inversion is in case of an MI. This is just something that nice to know. Like in MI patient, the T-wave inversion, both the limbs, that is the both the limbs of the inverted T-wave will be similar height, okay? But in case of a subarachnoid hemorrhage, the T-wave will be actually like asymmetrical. The limbs will be asymmetrical, height of the limbs. In Prinzmetal angina, which is due to coronary artery spasm, that can also cause ST elevation. Now you may ask me, like, how do we know this is a case of Prinzmetal angina versus this is a case of, for example, ST elevated MI? So both will be causing ST elevation, right? So normally in Prinzmetal angina or in case of a coronary artery spasm, usually T-wave inversion is not present. And even if it is present, you can confirm it by doing an angiogram. And in the angiogram, the coronary artery will not show any type of blockage. But, and in these kind of patients, like in Prinzmetal angina patients, only calcium channel blocker will actually provide significant symptomatic relief to those patients rather than the GTM. Okay. Let's try to solve this one. Question number 15. A 45-year-old woman suffering from sudden onset central crushing chest pain. Her electrocardiogram showed ST segment elevation. Tropi is slightly raised. She was rushed on an emergency invasive angiogram, but this revealed slight wall irregularities with no luminal obstruction. Subsequently, cardiovascular MR showed an apical ballooning of the myocardium resembling like an octopus pot. Okay, actually, this does not belong to this section. It would be better discussed in cardiomyopathy. Still, I'm hoping that some of you will be able to answer it. She did not have any significant past medical history. There's a family history of premature coronary artery disease. Her partner recently passed away of prostate cancer. So there is a history of some form of bereavement, okay? And there is apical ballooning, but there is no luminal obstruction. So the arteries are fine, okay? But the patient is complaining of chest pain. There is ST elevation, tropi slightly raised, and MRI shows apical ballooning resembling like that of an octopus pot. So what is the most likely cause of this ST segment elevation? Can anyone give me the answer?
Takotsubo.
Takotsubo cardiomyopathy, yes, very good. That's I did not understand that it would be given in this particular section because it's actually relevant for the cardiomyopathy section. However, it's very good that you understood this. Takotsubo actually the Japanese word for octopus. So that's why you get the octopus pot from the stem. You can just, like go straight to the Takotsubo cardiomyopathy. This is more commonly seen in female patients. And the basic mechanism is not known, but they say that because of beta adrenoceptor dysfunction, so in some genetically susceptible individual may experience this type of cardiomyopathy. And there is apical ballooning of the basically. And presentation can be very similar to like an MI, resembling like an MI. And usually some form of stress, anxiety, or bereavement process, these usually act as a contributing factor or exacerbating factor. So ST depression, causes of ST depression is not that much. It can be due to ischemia, digoxin, hypokalemia, and syndrome X. So not that important. Acute pericarditis will be causing ST elevation, not ST depression. All right. So hypothermia, what are the ECG changes for hypothermia? Bradycardia is a common presentation, J wave. So basically, so this is the QRS complex, right? But there will be like a notching present at the end of the, like this. Like this type of notching, this is known as the J wave, which can be seen in hypothermic patients. QT interval can be prolonged, and different types of atrial and ventricular arrhythmia can arise from hypothermia. In hypothermia, we know that ABCDE resuscitation protocol for emergency case management, right? Only hypothermia is the exception where exposure protocol is not followed. Rather than we will try to cover up the patient as much as possible so that basal body temperature is not lost. This is an exception for ABCD resuscitation management, and that is the hypothermia. Okay. Different types of pulse. This is again for theoretical purpose only, and for a basic portion. It will be discussed more in the basic clinical science, so you don't have to worry about that. So pulsus paradoxus is actually a misnomer, okay? Pulsus paradoxus has nothing to do with the pulse. It has to, it's basically, like blood pressure changes. With deep inspiration, what happens? We know that with deep inspiration, the intrathoracic pressure actually, it increases. When you take a deep inspiration, intrathoracic pressure increases and the venous return on the right side of the heart decreases. So which ultimately should be causing slightly fall within the systolic blood pressure. However, it should not be more than 10 millimeter mercury. If the systolic blood pressure changes, the drop is more than 10 millimeter mercury. So that is indicative of pulsus paradoxus. And this type of problem, this pulsus paradoxus can happen in severe pulmonary problems such as severe asthma, cardiac tamponade, when the cardiac capacity is not to the fullest. That's when this type of pulsus paradoxus presentation can take place. So the reason why I have said that this is a misnomer, although this is known as pulsus paradoxus, it's actually a change of the blood pressure, not the pulse. Slow rising pulse, this is seen in aortic stenosis, and collapsing pulse, basically high volume pulse. Also collapsing pulse has a different, previously it was called water hammering pulse. So basically it's a thrusting type of nature, the pulse feels like it's just, pushing on your finger. When you're examining the pulse with these three fingers, we usually assess for the rate, rhythm, volume, condition of the vessel wall, and all the characters of the vessels, right? Pulse, radio-radial symmetry, radio-femoral delay. So these are basically the examination steps of any pulse checking. So when you get like how to examine a water hammering pulse or collapsing pulse, so that, technique is a little bit different. So what you have to do is you have to we have to locate the radial pulse first, and then you should move your finger slightly downwards where you feel the pulse to the least. So in that area, when you feel that the pulse has become feeble, and now you wait for a couple of seconds in the lying position, and you have to press quite hard, and then ask the patient whether he or she has any pain in the shoulder region. So if the patient says, no, I don't have any pain in the shoulder region, that's when you suddenly just, raise the patient's hand and then wait for a couple of seconds. If the volume of the pulse hits back on your finger, that is indicative of water hammer pulse or collapsing pulse. So this is seen in aortic regurgitation, patent ductus arteriosus, and hyperdynamic circulation. So hyperdynamic circulation can take place when there is high cardiac output, for example, in anemia, thyrotoxicosis, pregnancy, fever, in this kind of situation. Pulsus alternans, the name alternans means alternative. So what does it mean? That the volume of pulse will be different in successive cycle. So in one phase, you are getting a weak pulse and then followed by a strong pulse. If you feel like the volume is different in each of this cardiac cycle, that is known as the pulsus alternans. So the main cause behind pulsus alternans when there is severe left ventricular failure. Bispherian pulse is basically two systolic peaks. So you will be feeling like two peaking at the same time. When you're feeling for the pulse, you'll see like two strokes are hitting your fingers. This is known as the Bispherian pulse. It can be seen in mixed aortic valve disease. So for example, in a patient with bicuspid aortic valve, has presentation both as aortic stenosis and aortic regurgitation, that kind of patients will be presenting with Bispherian pulse. Jerky pulse is basically the force of the pulse will be feeble and irregular, like not technically irregular, but it will the force will feel like different each time. It's very like these are all theoretical discussion. Once you start examining the patient, you will understand more and more. So jerky pulse is a term that is used to describe the hypertrophic obstructive cardiomyopathy related pulse, which is a genetic condition. That will also be covered in the subsequently in the next class regarding the cardiomyopathy class. So which one of the following condition is most associated with the Bispherian pulse? What is the answer? Bispherians, that means two systolic peaks, that is mixed aortic valve disease. Okay. This is a clinical question asking for a theoretical answer. So a 72-year-old man who has a history of ischemic heart disease and left ventricular dysfunction is admitted with dyspnea. He has not taken his diuretics for 3 days as he ran out. On examination, you note bilateral crackles on the mid zone and a respiratory rate tachypneic, that is 30 breaths per minute. Which other clinical finding is most specific with this type of presentation? Is it Bispherian pulse? Is it white pulse pressure, warm peripheries, pulse alternance, or fourth heart sound? So this patient is presented with left ventricular heart failure, and he has not been compliant with his medication for 3 days. So of course, there is an acute LVF going on. So in acute LVF patients, and in the chest examination, you found out that the patient has crepitation in both lung field. Patient is tachypneic. So this is obviously a severe LVF patient. So in this kind of patients, what type of clinical examination finding would you expect, particularly in the pulse examination? Pulses? Alternance. Yes. Now, we will discuss about the heart sound. So first heart sound is caused by closure of the mitral and tricuspid valve. We all know that. And the second heart sound is caused by closure of the aortic and the pulmonary valve closure. So first heart sound, it's when does the first heart sound become soft? So it can be soft when the mitral and the tricuspid valves are floppy. So the closure will not be as effective. Like imagine like the door of a room. So if you close the doors, it will produce a sound, right? But imagine these doors are floppy, like they're not like closing properly. So in that case, the heart sound, the sound will be more milder or softer, right? So similarly, in regurgitant murmurs, the heart sound will be soft. And in case of a stenost, for example, imagine the mitral valve, there is stenosis. So it will be like a very small amount of blood will be going from the left atrium to the left ventricle. And there will be, when it closes, it will need additional force because the passageway is already narrowed. So it requires more force to loudly close the doors. So that's why the stenosis will actually produce like loud first heart sound. And similarly, in the second heart sound, closure of the aortic and the pulmonary valve, this is soft in case of aortic stenosis. And second heart sound, there are actually like lots of different parameters of the second heart sound. So which will be discussed a bit later on. Third heart sound, this is due to the ventricular filling. Okay, I will just draw a diagram. So these two valve closure causes S1. And then you have the aortic and the pulmonary trunk. So here are the aortic and the pulmonary valves. So these two valve closure will cause second heart sound. All right. And when they're from the atrium to the ventricle, the filling of the ventricles, the blood that rushes from the atrium during the diastolic phases, that will produce some sound. That is known as the third heart sound. And finally, the stiff, for example, imagine that the ventricles have become stiff and hypertrophied, and the blood is not effectively pumped out. So against a closed valve, the atrial contraction will produce additional sound. This is known as the fourth heart sound. So third heart sound is almost always indicative of heart failure. This is also known as the gallop rhythm. And sometimes with, like very high quality stethoscope or phonocardiogram, you can also listen to the third heart sound in normal individual. Fourth heart sound, this is heard in aortic stenosis, HOCM, hypertension, when there is left ventricular hypertrophy, because it is caused by atrial contraction against a stiff ventricle. So the stiff ventricle, which can be due to hypertrophic changes. So HOCM, okay, that's all you need to know actually. So these are the main causes for producing fourth heart sound. S4 can never be normal, remember. S1, S2, S3, all can be heard in normal heart, but S4 is never heard in a case of normal patient. But I have never been able to detect S3 in my life. I can understand the different types of pathologies, like if the S1 and S2 is audible, whether the S1 is soft, whether the S1 is loud, or whether the S2 is, if there is any splitting, or whether this is loud or soft. I can appreciate those things, but in my practice, even with a cardiac stethoscope, I haven't been able to examine S3 and S4. So these are all just basically theoretical. All right. But you have to know about the causes. Like, for example, in aortic stenosis, because of the left ventricular outflow tract obstruction, there is a subsequent, like left ventricular hypertrophic changes, LVH happening. Or in systemic hypertension, there is a left ventricular hypertrophy. In HOCM, there is left ventricular hypertrophy. So against that stiff ventricle, when the atrium contracts, that can produce some additional sound, which can be manifested as fourth heart sound. So sites of auscultation, just I will draw the diagram. So basically, like in the left, this is left and this is right. So in the left fifth intercostal space along the mid-clavicular line, this is basically the mitral or the apical area. And this one right here, the in precordium examination, this is again undergraduation level, like study. So in the left fourth intercostal space, right, like in the parasternal region, this is known as the tricuspid region. This is the mitral or the apical region. This is tricuspid region. And this area, second intercostal space, second intercostal space, right along the parasternal region. This is known as the pulmonary area. And on the right side, second intercostal space, along the right parasternal region, this is known as the aortic area. So these are the basically 4 areas that we have to auscultate in case of a cardiac patient or any even respiratory patient. So when we are asked to examine the precordium, like in your undergraduation level, I'm pretty sure that you are asked to examine the precordium, right? So these are the 4 main areas that we have to examine. Like we have to first palpate this, we have to look at the position of the apex beat, and then we have to check for the, like if there is any thrill in these 4 areas, and if there is any different types of pulsation, and left parasternal heave and palpable P2. These are all part of, palpation. And then there is no percussion or anything in case of a precordium examination. We go straight to the auscultation. And we have to auscultate these 4 areas. That is either the mitral or the apical area, then the tricuspid area, and then the pulmonary area and the aortic area. And additionally, particularly for valvular heart disease, in order to locate if there is any like radiation, we have to subsequently, examine the axilla, especially for mitral regurgitation. And for aortic stenosis, we have to check for the root of the neck to see if there is any radiation, like systolic murmur radiation from aortic stenosis. So I'm not going into details about these particular information right now, because in the third class, we will discuss about the valvular heart disease and infective endocarditis. It will be discussed then. So here, this is just a visual representation. This is M, it stands for mitral area, tricuspid area. This is our pulmonary area, and this is a little bit downwards, but actually theoretically same side. Our on the left side, this is pulmonary, right side, this is aortic area. Can anyone tell me, like for aortic regurgitation patient, we usually tell the patient to, like sit upwards and then, like lean forwards, take a deep breath in and let it out and hold the breath. We have to give some instructions like that, right? And we have to put our stethoscope over very close to the tricuspid area. Can anyone tell me why do we do that? Why don't we just, like auscultate the aortic area for the aortic regurgitation murmur? Why do we have to check the tricuspid area for detection of aortic regurgitation murmur? So tricuspid area, this is also for aortic regurgitation only, this very area, that is third and fourth left intercostal space close to the sternal border. This is also known as neo-aortic area. The word is NEO, neo-aortic area. The reason behind this is like after the arch of aorta, when it descends, that is a very large and very accommodating artery. So a large volume of blood actually passes through the descending aorta. So in case of an aortic regurgitation, the regurgitant blood volume, actually, when we tell the patient to sit up, then the regurgitant blood volume from the aortic valve, like goes back through the descending aorta straight. And this blood volume rush, when it goes through the descending aorta, produces additional murmur. So that's why instead of, like examining for the aortic area, we go towards the tricuspid area because of the course of the aorta, actually. Nothing else. All right. I'm sorry if I'm going a little bit more details in cardiology, explanation. Actually, I have done my training in cardiology. That's why I get a little bit over enthusiastic in terms of explaining the basic physiology. I understand that not everybody is interested to know about how this happens or how that happens and stuff like that. I can literally give like 30 minutes of explanation behind the mechanism of white fixed splitting of the atrial septal defect for second heart sound, but I'd rather not. That will bore you. Okay. So question number 22, you can say 67-year-old man with a history of COPD and ischemic heart disease is taken to the emergency department with dyspnea. On examination, his respiratory rate is 24 breaths per minute. JVP is not elevated and crackles are heard in both lung bases. So which of the finding would be most strongly indicate that the dyspnea is secondary to the isolated left ventricular failure? Is it pulsus paradoxus? Is it gallop rhythm? Is it tachycardia? Is it peripheral edema? Is it cardiomegaly on the chest X-ray? Which one? It's a little bit tricky question. So the answer is actually B, gallop rhythm. Gallop rhythm is a very specific for left ventricular failure type of sign. Because in COPD patient with cor pulmonale, like this dyspnea can be due to either two possibilities: with complicated COPD presenting as a case of cor pulmonale. Cor pulmonale means heart failure secondary to lung disease. And cor pulmonale almost always means right heart failure, okay? And ischemic heart disease patient, they will have left heart failure or left ventricular failure. So in a patient with coexisting pulmonary disease and heart disease, they can be having biventricular failure or congestive cardiac failure. So both features of right and left heart failure will be present in this kind of patient. But here the information is JVP is not elevated. So that means the patient does not have cor pulmonale yet. And lung-based crepitation can be actually heard in both right and left heart failure. But gallop rhythm, this particular examination point is very much suggestive of pathology related to the heart, not to the lung. Okay. I hope this question will not come. This is a very theoretical question. Patient with severe aortic stenosis is noted to have a fourth heart sound. Which part of the ECG does it best correlate with? Any idea? A fourth heart sound is in correlation with, is it ST segment? Is it T wave? Is it P wave? Is it QRS complex? Is it U wave? So again, this is actually atrial contraction. So remember that even though the ventricles are stiff and the fourth heart sound is produced against a stiff ventricle because of the atrial contraction. So whenever the atrium word is used, so in the ECG, this is reflective of the P wave. So again, going back to the ECG, we know that the first positive deflection, that is the P wave. And P wave is due to, in the cardiac cycle, we have seen that 0 or rapid depolarization. So this rapid depolarization actually takes place because of the atrial contraction. So these things will be actually homologous. So P wave in cardiac action potential, P wave is indicative of phase 0 in the cardiac action potential, which is indicative of atrial contraction. And that will actually result in a first positive or upward deflection in the ECG P wave. So S4 is nothing but atrial contraction against stiff ventricle. So S4 will be represented as P wave in the ECG. Okay, let's try to solve a relatively easier question. 60-year-old man presents with increasing shortness of breath on exertion. During the examination, a third heart sound is heard. Examination of the respiratory system is unremarkable. So third heart sound, again, this is gallop rhythm. So which one of the following is most consistent with this finding? Is it dilated cardiomyopathy? Is it HOCM? Is it atrial fibrillation? Is it mitral stenosis or normal variant in this particular patient?
Dilated cardiomyopathy.
Dilated cardiomyopathy, yes, because it can lead to left ventricular failure. All right. So second heart sound is due to closure of the aortic followed by the pulmonary valve. So it has two components, that is the aortic component known as the A2 and P2. S2, A2, and P2. So it has like two components, okay? So the aorta actually closes fast first and then followed by the pulmonary valve closure. That's because of in relation to the respiratory cycle. Again, the explanation will be a lot, like lengthy. I will not go into details of that. This is the normal variant. So causes of a loud second heart sound, it can be most commonly loud S2 is due to pulmonary hypertension, okay? In case of systemic hypertension, S2 can also be loud, but the A2 component is more prominent, which is not always audible. So most commonly, pulmonary hypertension is the culprit behind loud S2. Causes of a soft second heart sound, that is because of aortic stenosis. In aortic stenosis, the aortic valve closure is actually hampered, which is why it will cause a soft second heart sound. Fixed wide splitting of the second heart sound results as a result, which occurs due to atrial septal defect or ASD. Wide fixed splitting can also take place, not fixed, but splitting of the S2 can also take place with deep inspiration or in pulmonary hypertension. And reverse or paradoxical splitting. So the P2 closure, P2 component is occurring before the A2. That can happen in left bundle branch block, severe aortic stenosis, and patent ductus arteriosus. These are the three examples that you have to know, must know. Okay. So here the second heart sound, loud in hypertension, soft in aortic stenosis, fixed split in ASD, reverse splitting in left bundle branch block. Most common, there are lots of pathologies you have already seen, but for exam purpose, loud S2, this is a sign of pulmonary hypertension, unless proven otherwise. Then soft S2, this is seen in aortic stenosis. Wide fixed splitting. This takes place in ASD or atrial septal defect. And no, not fixed, but splitting of the second heart sound can happen with deep inspiration and sometimes with pulmonary hypertension, apart from the ASD. And reverse splitting. So that is P2 is happening, P2A2. Reverse splitting is almost always due to left bundle branch block and severe aortic stenosis. So in aortic stenosis, second heart sound can be soft, and in case of severe aortic stenosis, it can be reversed splitting of the second heart sound. Murmur, actually, I don't want to go through the murmur discussion right now because once we are going through the valvular heart disease, this murmur will be eventually grasped by you. And also, like these different types of murmur, you have to like examine the patients, then you will be able to correlate it. Hopefully, in the MRCP part 1 and part 2 examination, they will give you like further information from the stem, which will help you to pick out the diagnosis from the given options. For exam purpose, without examining the patient, for like MCQ purpose, you have to just, like cram this information. There is no other ways, actually. So ejection systolic, there's an easy way to remember this, I think, that will help you at least for you don't have to go through like whether this is causing ejection systolic or hollow systolic or pansystolic, or this is a case of early diastolic or mid diastolic, like not necessarily, but there's a easy mnemonic that can help you like at least get down to the basics. That is, in the base of the heart, if you look at the heart, the base of the heart is actually these portions, right? In the base of the heart, the aortic and the pulmonary valves are more in close proximity. And towards the apex of the heart are the mitral and the tricuspid and the mitral valves, right? Aortic and the pulmonary valves. So valves that are close to the base of the heart, that is aortic and pulmonary valves, if the stenosis is taking place, it will cause systolic murmur. So only this information will help you give the rest of the information additionally. How? For example, aortic stenosis, it will cause systolic murmur. Pulmonary stenosis, it will cause systolic murmur. Aortic regurgitation, so the opposite will be taking place. It will cause diastolic murmur. Pulmonary regurgitation, opposite will be happening. So it will cause diastolic murmur. And mitral stenosis, opposite to the base of the heart finding. So in mitral stenosis, there will be diastolic murmur. Tricuspid stenosis, there will be diastolic murmur. Mitral regurgitation, there will be systolic murmur. Tricuspid regurgitation, there will be systolic murmur. So either way, you can remember. I used to remember like the valves that are close to the base of the heart. If there is stenosis, that will produce systolic heart. So for like rest of the information will be just, like vice versa for the opposite side of the heart. Okay, JVP, need to show the waves first. So here you can see like the JVP is actually has like two peaks, that is A wave and V wave. So these are the mainly two upstrokes, important upstroke, and then there is a downstroke like the X and the Y descent. So what is the C wave? That is in between the downstroke, there is a slight notching, that is the C wave. So now let's get back to this portion. So A wave, basically JVP or the jugular venous pressure, that is estimation of right atrial pressure. We know that in the right atrium, the superior vena cava and the inferior vena cava opens, right? So that's why the venous pressure will be a very close reflection of the right atrial pressure. So in what are the conditions where there is non-pulsatile JVP? So in the neck, we usually check the JVP in the root of the neck and lateral to the sternocleidomastoid, sorry, medial to the sternocleidomastoid muscle, or in between the two heads of the sternocleidomastoid muscle. And we have to tell the patient to sit in a 45-degree angle. And we tell the patient to look on the other side, and on the right side of the hand, we usually shine like some form of light, and then we check for if there is any visible pulsation. So normally you can see that this JVP has two diachrotic pulse, but in certain condition, there will be non-pulsatile raised JVP. That can take place if there is in thoracic inlet obstruction, commonly in Pancoats tumor or in apical lung cancer, if it is obstructing straight on the superior vena cava. So that can cause a non-pulsatile or fixed raised JVP. So in these patients, what happens, this type of, apart from this non-pulsatile JVP, these patients also have other features of, thoracic inlet syndrome. Not sure if you have heard about the Pemberton sign. So Pemberton sign is basically when you tell these patients already look, flushed and plethoric. So in Pemberton sign, if you tell the patient to raise their arms above the level of the, head, so that's when all the blood are actually rushing in a congested place. Bloods are already congested because the superior vena cava is obstructed from outside compression, maybe because of a apical lung cancer. So when you tell the patient to raise their hands above the head level, so again, a blood flow is, rushed in a stagnant area that causes more, plethoricity or more facial flushing. That is known as the Pemberton sign. Anyway, and Kussmaul sign, this is normally in deep inspiration, there should be like a fall in the JVP, because with deep inspiration, again, intrathoracic pressure rises and the venous return on the right side decreases, which as the venous return decreases, so the JVP should be also falling. That is happening in a normal patient. But in case of a constrictive pericarditis, because there is some form of constriction on the heart, so the heart is not able to pump properly. So the venous return actually with deep inspiration will increase, which in turn will cause a paradoxical rise in the JVP. This is known as the Kussmaul sign. This is indicative of constrictive pericarditis. So normally in JVP, you can see that A wave, the first upstroke, this is indicative of atrial contraction. A for A, atrial contraction. So in cases where the atrial pressure is increased, for example, in tricuspid stenosis, pulmonary stenosis, or pulmonary hypertension, the A wave is also large. A wave is absent in case of atrial fibrillation. Canon A wave, like I've already mentioned, that can happen in case of complete heart block. And nodal rhythm and ventricular tachycardia or ventricular ectopics, canon A waves can also be present, but common cause behind canon A wave is complete heart block. C wave, not that important. A wave and V wave, these are the most important, parts for JVP. And what are the pathological conditions for canon A wave and giant V wave? These are the important information from JVP. C wave takes place because of the closure of the tricuspid valve. C for C, closer. This is not normally visible. V wave is due to the passive filling of the blood into the atrium against a closed tricuspid valve. So basically, when the blood enters into the atrium, that causes the V wave. Giant V wave takes place in tricuspid regurgitation. X descent and Y descent basically fall in the atrial pressure, and Y descent finally when the valves open up and from the right atrium, the blood goes into the right ventricle, that causes the Y descent. So important one being the A wave and the V wave. Can anyone tell me the differences between how do you differentiate carotid pulse and JVP? Anyone? Which one is better seen and which one is better felt?
Carotid.
Carotid is better felt and better seen is JVP. Carotid is single upstroke, but dichrotic or double upstroke is present in JVP. Then carotid pulse, if you compress on the root of the neck, the carotid pulse will not disappear. You can still feel it. But if you compress the root of the neck, the raised JVP will disappear. And hepatojugular reflux, which is basically if you compress over the liver, and then the height of the JVP, height of the pulse is increased, that indicates the JVP, not the carotid pulse, because liver, right behind the liver is the inferior vena cava, which is why if you press over the liver, then it will increase the height of the JVP. And with inspiration, there is no changes of the carotid pulse with inspiration or expiration. It will be static. But in case of the JVP, normally with the height of the inspiration, JVP should tend to fall a little bit. But if there is a paradoxical rise in the JVP, that sign is called Kussmaul sign. This is indicative of constrictive pericarditis. Okay. Which part of the jugular venous waveform is associated with opening of the tricuspid valve? So A wave is due to atrial contraction. C wave is because of the closure of the tricuspid valve. X descent is because of the fall in the atrial pressure. V wave is due to passive filling within the atrium. And Y descent is when the valve finally open. The tricuspid valve finally open. Tricuspid valve is lying between the right atrium and the right ventricle. So all of this time, we are discussing about the right atrial pressure. So Y descent, it's done by when the tricuspid valve opens, finally the blood in the right atrium goes into the right ventricle. That causes the final descent. This is the Y descent in the JVP. Okay. Which part of the JVP is associated with a fall in the atrial pressure during the ventricular systole? The answer is X descent. Okay. Which part of the JVP may be exaggerated in tricuspid regurgitation? I hope everybody should get this. In tricuspid regurgitation, the additional amount of blood is going from the right ventricle to the right atrium, right? So that's why it should cause a increased height of the which wave in the JVP? Giant V wave. Okay. So I think you have to go through this information by yourself a little bit, 2 to 3 times, and then it will be more easily understandable. Still, I can again draw a diagram. Mainly, when it comes down to JVP, you see that this is the superior vena cava, this is the inferior vena cava, and this is the tricuspid valve. So the jugular venous pressure basically is indicative of the right atrial pressure within the right atrium. And in conditions when the right atrial pressure, either due to pressure overload or because of volume overload, when the right atrial pressure increases, that will cause a raised JVP. So for example, in a superior vena cava obstruction, it will cause a raised JVP. If there is a for example, pulmonary stenosis, this is where the pulmonary trunk, we know that from the right ventricle, the pulmonary trunk arises. And here is the pulmonary valve. So in case of a pulmonary stenosis, the blood is not able to pass through properly from the right ventricle, right? So the blood is going again back to the right atrium. That will cause volume overload here within the right atrium. So that will increase the pressure within the right atrium. So that will also cause increased JVP. Again, if you ask me to write down what's the mechanism of tricuspid regurgitation causing a raised JVP, the answer is very same. The tricuspid valve is floppy here, which is why with each contraction of the atrium, not all of the blood is able to go effectively into the right ventricle. So there is always more or additional amount of blood staying stagnant within the right atrium, thereby leading to volume overload within the right atrium, leading to a raise in the JVP. Okay. In pulmonary hypertension, what happens in the pulmonary trunk? There is pressure overload. So because of the back pressure, the pressure builds up within the right atrium. So that will subsequently lead to rise in the JVP. Okay. So if behind each of these, like examples, if you just think commonly, like any pathology involving particularly the right side of the heart can actually lead to the rise in the GVP. Okay. So far we have gone through like some ECG changes, action potential, electrical conduction of the heart. We have gone through like different types of heart sound, different types of pulses, JVP, and very basics of the cardiology. In the second section, I will take like a 10 minutes of break, and then I will start with the second session on the cardiac arrhythmia. And we will also cover like some important information regarding the, like peri-arrest tachyarrhythmia and peri-arrest bradycardia and ACLS protocol. We will discuss about that. So that portion is very important. Hopefully you will be, like present during that second session. I will resume in 10 minutes. Thank you. Sure. Okay, welcome you all to the remainder of the second session on cardiology, where we will be focusing solely on the cardiac arrhythmia. So in terms of cardiac arrhythmia, basically this is a problem within the electrical conduction system of the heart. So broadly, I have also already discussed about the broad classification and some of the emergencies in the previous class. But I will be recapitulating those information in this class also. So don't worry about that in case you have missed that information in my earlier class. So normally in any patients with any form of electrical abnormality, the first common complaint that they presented with is either palpitation or syncope. So palpitation or racing pacing of the heart. In terms of palpitation, some of the from history, when we're asking the patient, like how did it start, the onset is very important to ask. For how long the patient has been, like suffering from this type of palpitation, and is it occurring frequently every day or every alternate day? Or when the patient has this, like episodes of irregular heartbeats or, like racing pacing of the heart, that time has the patient ever felt for his own pulse? Because we do that in our own, whenever we are feeling, like palpitations within ourselves, we usually try to feel our pulse by ourselves. So we also ask the patient, like, did you feel the pulse yourself? Have you counted the rate? Was it regular, irregular? Can you tap it out for me? So these are the common questions. Or whether these palpitation episodes are more when you're trying to exert yourself, or does it happen during your sleep as well? Is there any particular food, medicine, or any stress, anxiety relevant that can, like provoke your palpitation episodes? Is there anything that you have done to relieve your symptoms? So this is how in a patient with palpitation, we usually, like start with asking questions. In terms of possible causes, like the palpitation possible causes are, apart from cardiac arrhythmia, it could be entirely due to some, like stress induced or anxiety. Generalized anxiety disorder can also cause palpitation, and some other non-cardiac cause, for example, thyrotoxicosis, that can also cause palpitation in a patient. Another endocrinological condition known as pheochromocytoma. So that's basically a disease of an adrenal gland, particularly adrenal medulla, when the adrenaline and noradrenaline are secreted excessively. This is basically a type of tumor. So if pheochromocytoma patient, they also have like lots of adrenaline in the body that can also produce, like palpitation. In premenopausal, postmenopausal patients, this type of like palpitation kind of problems can take place. So there are lots of possibilities, and in common cause that we usually like overlook, that is in female patients, anemia can also cause like significant palpitation that we sometimes like ignore. So normally any patient with palpitation, we usually start off with an ECG, 12-lead ECG. However, in patients who do not, who have, but it actually like captures the heart rhythm for a couple of seconds only. Like we take the ECG for one sitting or one occasion. We are not evaluating the heart rhythm for the entire day. So that's why if it is a paroxysmal variety, then this type of arrhythmia can be easily missed on the 12-lead ECG. If it's a persistent atrial fibrillation, or if this is a ventricular arrhythmia, that can be easily picked up on the ECG because it's a single capture of the heart at one moment of the heart, at one particular moment. So episodic arrhythmias can be missed in 12-lead ECG. For that, we will do some additional tests. I will come to that a bit later. Then thyroid function test, again, an important blood parameter that we must give in a patient with palpitation because TSH can be low and T3, T4 can be high. That is indicative of thyrotoxicosis in any patients with palpitation. And it can not only, it can directly cause palpitation in pre-existing palpitation or pre-existing cardiac arrhythmia, thyrotoxicosis, if it is not corrected, then it can also accentuate this kind of problems. Serum urine electrolyte, lots of time electrolyte imbalance is the sole culprit behind any type of arrhythmia. So that's why we have to assess for this disturbance, like for example, low potassium, low magnesium, low calcium levels. All of this can precipitate arrhythmia. Full blood count, particularly CBC and hemoglobin levels, that should be assessed. Concurrent infection, for example, in a patient with infective endocarditis, they can also present with palpitation. So before going for echocardiography or blood culture, we can, like take some initial thinking, like this patient might be in chest examination, I found a murmur, patient is complaining of palpitation, and now in the ECG, I have seen that there is prolongation of the PR interval, and in the CBC, I can see that the WBC count is quite high. So this is, we do not diagnose a particular disease only from the basis of a history or only from the basis of clinical examination. Always one thing is interconnected with the other, and we have to just combine these threads together in order to diagnose a certain disease. Now, in terms of episodic arrhythmia, the investigation of choice is Holter monitoring. So Holter monitoring is basically a device connected to the body, but only externally. It's either, like taped or, basically they usually use the tape, this device, external device, and they record the electrical activity from outside of the heart throughout the day, either for 24-hour, 48-hour. The highest it can capture is 72-hour Holter monitoring. So actually, my mother, she has premature ventricular contraction PVC. And for her, we had to do lots of tests and investigation. We did not want to go for the invasive test, that is basically the electrophysiological study, EPS, because EPS has its own demerits or disadvantages. So that's why we went for the Holter monitoring for her. But after the report came back, we have seen that in a single run, the number of PVC episodes were not significant enough. So that's why we took her to Delhi. I think the Delhi candidates here, they can correlate. This is called Max Super Specialty Hospital. And cardiologist T.S. Clare, he has seen my mother. And he reassured us that actually she does not need any particular medication or any type of intervention. Given that if she's stress-free and goes for lifestyle modification, this type of PVCs are not that pathological. But we did lots of tests, and the reason why I'm talking about this, I've seen steps of Holter monitoring right before my eye. So that's why I'm very much, familiar with this type of devices. It's a portable battery-operated device, continuously records ECG from 2 to 3 leads, usually done for 24 hours, but it can be extended for 48 to 72 hours even. Patients are asked to keep a diary. So patients are asked to, whenever they're feeling like a drop beats or, episodes of palpitation, they're also asked to mention the time and the date and basically at what time they felt that kind of symptom. And then it is actually, compared to the rhythm strip at that time, the device is also collecting the, electrical activity information at the same time. So these two information, like the patient diary, when the event or the symptom has taken place, that is compared to the rhythm strip on the Holter monitoring strips. And at the end of the monitoring, a report is generated. So it's like a entire book. If it is done for 48 hours, the book becomes containing these pages. There are multiple readings of ECG, one after another. So finally, they have their own calculations. They have their own mathematical test, which converts the summary of the entire, like monitoring. And they mentioned the, like number of times that those, like ectopic beats has taken place, and whether these were symptomatic or asymptomatic, that is again monitored against the patient's record. And the heart rate, arrhythmia, and everything is actually put together in the bottom of the book. If there is no abnormality found in the Holter monitoring and the symptoms continue, other options might be external loop recorder or implantable loop recorder. But these are actually not available in our country, these loop recorders. That's why if in Holter monitoring, these, like paroxysmal or episodic arrhythmias are not detected, in the next level, we usually go for something invasive, that is the EPS or the electrophysiological study. And even in our country, there is not many EPS specialists. Actually, in EPS, it's a very similar procedure like the angiogram. But with the scar formation that can take place in EPS, and from this scar, it can sometimes act itself as like an arrhythmogenic, foci. So that's why, like when you're a doctor, you would not be given the risk-benefit ratio. It's always a risk-benefit ratio. In a young patient who is suspected to be having any, like WPW syndrome or something, Brugada syndrome, something like that. In those patients, you will definitely say, okay, I want to, like given the risk, because there is a possibility of doing some form of intervention through that EPS study, you will be willing to go through these EPS studies. But in elderly patient, you know for sure that the patient does not have any comorbidities, or like patient has no structural heart diseases and everything, and it's very unlikely that at an elderly age he or she will develop any like inherited conditions. So in that case, and the patient most of the time remains asymptomatic. In that case, invasive tests are not actually like suggested. But then again, it's a very super specialty level decision. And this type of decision only comes after, consultation with a, like EPS specialist. Okay, let's try to solve this question. 53-year-old man presents as he's worried about the palpitation. They're described as fast and irregular, typically occurring twice a day. They seem to be more common after drinking alcohol. There is no history of chest pain or syncope. Examination of his cardiovascular symptoms normal, with a pulse of 72 beats per minute and a blood pressure normal. Blood test and 12-lead ECG are unremarkable. What is the most appropriate next step in the management? Do you reassure the patient and repeat the 12-lead ECG in 3 months' time? Request a tropi, arrange for an echocardiogram, arrange for a Holter monitor, or arrange for an external loop recorder? Which one is the most plausible thing to do here? So the patient does have, like fast and irregular, typically occurring twice a day, but ECG can be normal because this is an episodic arrhythmia. He has no comorbidities. Cardiovascular examination is normal. There is no chest pain or syncope. So that's why troponin I requesting is not really done here. Echocardiogram likely will not provide any additional information because the patient will probably have no structural heart disease either. Reassuring the patient and repeat the 12-lead ECG in 3 months' time, but the patient is having symptoms twice a day. So in that case, there is no, like possibility of waiting for 3 months' time here. The thing we can do here, instead of going for an external loop recorder, the first next step management can be done with the help of Holter monitoring. But if Holter monitoring is non-conclusive, in that case, we can go for an external loop recorder. Okay, now we will discuss about the advanced cardiac life support, or ACLS. So every one of you who is interested to work in the NHS or maybe in any other country, like one of my colleague is actually working in Dubai. He had to, like pass the Dubai medical counseling exam after clearing the MRCP exam. So they have to take this mandatory, like ACLS workshop in their own country, because every country, even though this is like a very international guideline directed program, however, every country have their own protocols at the same time. So because the patient variety is different, patient presentation can be, like different based on the geographical setting, which is why wherever you move, you have to take that particular country's, ACLS workshop. And it's very, very important as a medical officer, whether you work as a junior or mid-level or senior level, you always have to deal with emergencies, and you have to be prepared so that you can give the initial, like at least the emergency management of cardiac arrest protocol. That should be maintained by you. So in most of the time, ACLS actually basically starts with whenever you can't detect a pulse. This is when the ACLS protocol begins. So it can be either a pulseless ventricular tachycardia, it could be pulseless electrical activity, it could be cardiac asystole. However, we're not getting a pulse, we will, call for the code blue, call for senior help. The crash cart will be available in very, promptly, and we have to start with a CPR. That's the main thing you do first, okay? So the ratio of chest compression to ventilation is 30:2. So chest compression, 30, after 30 chest compression, you have to give like back-to-back 2 mouth-to-mouth breathing or blows. Chest compressions are now continued while a defibrillator is charged. So defibrillator is actually given with the help of a paramedic. And if there is any cervical or neck injury or something like that, then you have to protect the cervical spine beforehand. And if there is in recovery position, you should keep the patient like the chin is usually lifted. But you have to be careful in terms of a cervical injury, head injury patient, because you should not be, like manipulating the cervical spine. But we're actually now, since we're discussing about the cardiology section, we will actually omit the head injury section here. We will discuss about the cardiac arrest protocol. So during, all right. Meanwhile, whilst you are, like giving chest compression, you will tell, other medical doctor or nurse or whoever is available, you will tell that other person to give, like mouth-to-mouth blow. Or if you are not confident with the chest compression, you should be the person, like giving either suction through the, like ambu bag or through mouth-to-mouth. In the hospital setting, you're not, mouth-to-mouth breathing is actually advised for, like passerbys or non-medical professional. But once you're working in the emergency department, of course, you will have, like access to the ambu bag. Then you're supposed to give the, or the breathing masks. You can just give the, blows with the help of that device. And you have to request for a defibrillator, keep the defibrillator charged and ready. So once the charging is done, so there should be a command from the paramedic who has just prepared that, like defibrillator. He should be yelling like, I'm clear, you're clear, all are clear. Then start with, like 160 joule initially. But before giving the, like defibrillator or the shock, patient, there should be restoration of the pulse. If you're not getting pulse, continue with the CPR or at least 2 minutes of CPR. Okay, so previously in ACLS protocol, they used to say that, first shock should be given after effective 1 cycle of CPR. But nowadays it's obliterated. You have to continue giving CPR for 2 minutes. And if you are not getting a pulse, then if you get a pulse or don't get a pulse, doesn't matter, give the CPR for 2 minutes and then you start with the defibrillator, not before that. Because CPR is the only thing that will help the patient to come back to life. During a ventricular fibrillation or ventricular tachycardia cardiac arrest, adrenaline 1 milligram is given once the chest compressions have restarted after the third shock, and then every 3 to 5 minutes. So for example, you have given the CPR for 2 minutes, followed by the first DC shock. The DC shocks, actually synchronized DC shocks, are given successively 3 times. So starting with the 160 joule, and then the second one is 300 joule, and the third one is 300 joule. After giving this third shock, you have to prepare for an adrenaline and amiodarone loading dose. Adrenaline is given 1 milligram stat, followed by 3 to 5 minutes. And amiodarone 300 milligram is also given after the third shock. Atropine is no longer recommended, so we are not going to be discussing about atropine anymore. Single shock for VT or pulseless VT, followed by 2 minutes of CPR, rather than a series of 3 shocks followed by 1 minute of CPR. So that basically means if this is a case of cardiac arrest, just start with the chest compression and ventilation, continue the CPR for 2 minutes. And meanwhile, you can tell the other staff members to prepare for the, prepare with an adrenaline and amiodarone, and you tell the other person to be prepared with the DC shock. And after 2 minutes of successful CPR, then you can give the first shock, followed by second shock. And before giving the third shock, you can give adrenaline injection. Then the third shock is given. And after the third shock, you can start with a loading dose of amiodarone. And then the cycle can be repeated until you get a restoration of the sinus rhythm. This is the ACLS main, like protocol here. Asystole or pulseless electrical activity should be treated with 2 minutes of CPR rather than 3 prior to reassessment of the rhythm. So every 2 minutes, you have to check for the carotid pulse, whether you are getting any pulse or not. Delivery of the drugs by tracheal tube is no longer recommended. And after the resuscitation, oxygen should be titrated because you do not want to give over oxygenation of the patient, because there is always chances of free radical injury because of hyperoxygenation. So oxygen saturation should be maintained within 94 to 98% unless the patient is known to be having COPD. In COPD patients, the target oxygen saturation is slightly lower, that is 88 to 92%. So you're called to assess a man who has collapsed in the clinic waiting room. A staff nurse has already been bleeped the cardiac arrest team. On arrival, the man is laid on his back. You open the airway with a head tilt, chin lift. After assessing for 10 seconds, there are no signs of breathing. What is the most appropriate next step? Is it start the chest compression at a ratio of 15:2, place the patient in recovery position, check for carotid pulse for 10 seconds, give 2 rescue breaths, and start chest compressions at the ratio of 30:2? The answer is, as you're not, the patient has already collapsed, cardiac arrest team has been called, and there is no breathing. So the patient has already gone to respiratory arrest. So you start with CPR. That is at the ratio of 30:2. 15:2 is not a ratio for CPR. And recovery position is given in patients who are, like having to be any suspected head injury or spine injury. In those patients, recovery position, or epileptic patients, that is the first thing you do. Okay, now we will discuss about the peri-arrest rhythm or tachycardia. Okay, let me. So in my previous class, I was actually discussing about, like most commonly the cardiac arrhythmia can be, like narrow complex and broad complex. That is QRS complex. So narrow QRS complex and broad QRS complex. And within the narrow QRS complex, it can be regular rhythm, irregular rhythm. So if this is regular rhythm, then narrow QRS complex, most likely the common arrhythmia would be supraventricular tachycardia. If it is irregular rhythm, then most likely this is atrial fibrillation. Okay, and in case of a broad QRS complex, again, it can be divided into regular and irregular. So for regular, this is most commonly broad complex QRS is ventricular tachycardia, and for irregular, this is polymorphic ventricular tachycardia. Another can be a possibility of atrial fibrillation with bundle branch block. But polymorphic VT is the more common one. So we will, in peri-arrest tachycardia, we will actually focus on these particular 4 different types of arrhythmia. So always remember, like, if there is any mention of adverse signs, so what are the adverse signs? If there is any mention of the adverse sign, you have to start with the DC shock first, rather than any type of chemical or, like drug ailments. So what are the features of adverse sign? If there is any mention of syncope, if there is any mention of myocardial infarction or ischemia, if there is any, or ECG changes, if there is any mention of heart failure, cardiac arrhythmia with heart failure, and if there is any patient is in cardiogenic shock, or if the patient is hemodynamically, cardiogenic shock and hemodynamically unstable is basically the same thing. That is the systolic blood pressure and the diastolic blood pressure is less than 90/60, and patient is tachycardic, patient is having cold and clammy hands and all these things. So that is, these are basically the adverse signs: syncope, shock, and failure, MI. So if there is any mention of these adverse signs, then the first thing for any type of arrhythmia that you do, that is give DC shock, the 3 successive DC shock, and then do the rest of the things that you need to do. Now, we will start with a VT, ventricular tachyarrhythmia management. So for ventricular tachyarrhythmia management, so before that, we need to know like what are the different types of VT. So I have already mentioned like monomorphic VT. First, it can be pulseless VT and VT with a pulse. So if it is pulseless VT, it will be within the ACLS protocol, okay? Because this is a cardiac arrest arrhythmia. There are actually 4 different types of cardiac arrest arrhythmia, and pulseless ventricular tachycardia is actually one of them. So that's why we will follow the ACLS protocol. In a pulse, in VT with a pulse, there are 2 different types mainly. One is the monomorphic VT. So here, all the QRS complexes will be actually similar pattern or similar looking. And the other one is the polymorphic VT. So the morphology of the ventricular tachycardia will be different in successive leads or successive cardiac cycle, polymorphic VT. One of the subvariant of the polymorphic VT is actually called torsa de Pointes. So basically the QRS complex is twisting around the T-wave axis, which causes this polymorphic VT, and it can be precipitated due to long QT. I will discuss about the long QT later. And so we have the monomorphic VT. So if there is any adverse sign in any either of these type of varieties, we will start with the DC shock. Like if the patient is in shock, hemodynamically unstable, patient is in cardiac syncope, patient has heart failure, MI. In that case, we start with the DC shock. We seek for expert help, start with the DC shock. Before that, we sedate the patient, and first shock is 160 joule, followed by 300. Third shock is 300. We have to open up an IV and give loading dose amiodarone 300 milligram over 20 minutes. Then we can, open up a CV line and give further, doses of amiodarone 900 milligram, usually given via the CV line over 24 hours. And then we have to, if the patient is still deteriorating, we can further, give DC shock. Meanwhile, we have to correct for the electrolyte imbalance. And in case of a refractory patient, if everything fails in that case, we can choose the other second antiarrhythmic drugs such as lidocaine and overdrive pacing. This is actually done for bad cases of ventricular tachycardia. But if the patient is not having any of the adverse sign, in that case, we will try to, correct for any electrolyte abnormality and give IV amiodarone. Okay, so amiodarone here is the main treatment for ventricular tachycardia. In polymorphic VT, you have to give IV Maxal. IV magnesium sulfate is given, loading dose is 2 gram IV. Okay, and amiodarone loading dose is usually 300 milligram. Other antiarrhythmic drugs that can be used is lidocaine, procainamide plus minus. So these are basically the drugs for management of ventricular tachycardia. But in VT patients, never, ever give rate limiting or cardioselective calcium channel blockers. Never. Because it will cause significant, myocardial depression, and it will further exacerbate the ventricular tachycardia. So you should not be giving cardioselective calcium channel blockers such as verapamil or diltiazem in the management of ventricular tachycardia. Okay. Next up, we will discuss about the polymorphic VT or the long QT syndrome. So as I've already mentioned, polymorphic VT basically means that the morphology of the ventricular tachycardia is different in each of the cardiac cycle or successive leads. So one of the variant is torso the pointus, and that can be accentuated by long QT syndrome. So long QT, we will actually mainly focus on the long QT syndrome. So causes of long QT syndrome is actually divided into like congenital causes and acquired causes. Acquired causes can be further. Among the congenital causes, one of the common causes is Jervell-Lange syndrome and Romano-Ward syndrome. In Jervell-Lange syndrome, there is usually associated with sensory neural deafness. In Romano-Ward syndrome, there is no deafness in these kind of patients. And these congenital long QT syndrome patients, they are presented with long QT at a very young age, and it can be further accentuated by stress, anxiety, exercise. Sometimes even during rest, congenital long QT syndrome can take place, these attacks. Acquired long QT syndrome, common causes are drug causes, electrolyte imbalance, cardiac and non-cardiac causes. For exam purpose, drug causes and electrolyte imbalance is the most important cause for long QT. So for drug causes, you will see that SSRI, there are actually like loads of drugs that can cause long QT, but among these, I will actually focus on the most important one, SSRI, tricyclic antidepressant, antipsychotic, macrolide antibiotic, and antihistamine. Among the antihistamine, terbinafine mainly, not the fexofenadine. Fexofenadine does not cause long QT. So if you're suffering from allergic rhinitis or any other, like allergy problems, and you're on maintenance dose of fexo for a long time, you don't have to worry about that. Terbinafine mainly causes the long QT syndrome. So these are the main or important drugs behind causing long QT, drug causes for long QT syndrome. And for the electrolyte imbalance, important would be hypomagnesemia, hypocalcemia, hypokalemia. They can cause long QT syndrome. And from the non-cardiac cause, hypothermia and subarachnoid hemorrhage, they can cause long QT syndrome. These are actually the common exam-related causes, but there are other causes which I will go through. You'll see. So this one, this box I was talking about, Jervell-Lange-Nielsen syndrome associated with deafness and due to abnormal in the potassium channel. And Romano-Ward syndrome, there is no deafness. Drug causes, among the drug causes, class 1 antiarrhythmic, forgot to mention that is amiodarone and sotalol, tricyclic antidepressant, antipsychotic, and SSRI, fluoxetine, antidepressant, tarfenadine, and not terbinafine, tarfenadine, antihistamine, and erythromycin, macrolide antibiotic, and antimalarial chloroquine. These are the drugs that can cause long QT. And electrolyte imbalance, hypercalcemia, hypokalemia, hypomagnesemia, acute MI, myocarditis. These are cardiac causes, and non-cardiac cause would be the hypothermia and the subarachnoid hemorrhage. So these are the main causes for prolonged QT interval. The reason why I'm focusing so much on this box is I got 2 questions from long QT syndrome in my part 1 examination. So imagine that you're getting only 15 questions from cardiology, and back-to-back 2 questions are coming from this particular single box. So that means it has lots of importance in this box. All right. So management is for, if there is adverse sign presence, we will start with the DC shock, like as usual. And for drug therapy, for polymorphic VT, IV Maxalf, and for maintenance dose amiodarone, central line should be preferred. And verapamil should not be used in treatment of VT. And if drug therapy fails, in that case, interventions such as EPS, implantable cardioverter defibrillator, these can be used. Okay, now we will go through some other special topics. Like, I think I have already mentioned the multifocal atrial tachycardia and CPVT in my previous class, but it's okay, I will go through that again. So multifocal atrial tachycardia, it's actually irregular cardiac rhythm caused by, so normally we know that the SA node is the main, like place where the electrical conduction of the heart takes place. But in case of a multifocal atrial tachycardia, you see the word multifocal. That means that foci will be within multiple sites of the atrium. So when multiple sites of the atrium starts generating, impulses, that is known as multifocal atrial tachycardia. So it can be demonstrated by morphologically distinctive P waves. And it is more commonly seen in elderly patients with chronic obstructive lung disease or COPD patients. So here, mainly treatment of the underlying disease, that is correction of the hypoxia and treatment of the COPD. If there is an electrolyte imbalance, that should be corrected. Rate-limiting calcium channel blockers are often used as a first line here. Cardioversion digoxins, these are not useful in the management of treatment for MAT. Mainly here, treatment of the underlying cause, that's the main treatment. Okay. In case of a CPVT, this is a rare inherited cardiac disease associated with sudden cardiac death, autosomal dominant in nature, pathophysiology defect in the RYR2 receptor, which is ryanodine receptor in the myocardial sarcoplasma reticulum. And this type of CPVT or catecholaminergic polymorphic ventricular tachycardia, it also goes within the polymorphic VT variety, but it's very rare actually. It's a congenital form of polymorphic VT. Exercise and emotion or like sudden stress, they can all precipitate. Symptoms generally develop before the age of 20 years. Management is in the form of beta blocker and implantable cardioverter defibrillator. So ICD is actually given to most of the patients on a prophylactic basis who have like any type of familial condition. They have more chances of developing sudden cardiac death. In that case, prophylactic basis, we can give implantable cardioverter defibrillator, because in those patients, they can predict the VT or VF and terminate internally. Like, for example, ARVC or arrhythmogenic right ventricular cardiomyopathy, then Brugada syndrome, WPW syndrome, hypertrophic obstructive cardiomyopathy. So these are some other familial cardiologic or cardiac conditions where the implantable cardiac defibrillator is given for treatment purpose. Okay. Broad complex tachy, we have gone through that. So Valsalva, no, we will go through the SVT first, and then we'll discuss about the Valsalva. So supraventricular tachycardia, in my now I have mentioned that this goes within the category of a narrow QRS complex. If the rhythm is regular, then most likely the culprit is supraventricular tachycardia. If it is irregular, then this is atrial fibrillation. So for supraventricular tachycardia, it's actually any tachycardia that is not ventricular in origin. That is supraventricular. Actually, different types of arrhythmia, you can, most common variety is the broad QRS complex versus narrow QRS complex, and then further dividing them into regular, irregular, or you can also remember it like supraventricular and ventricular arrhythmia. Supraventricular arrhythmia would be atrial fibrillation and SVT mainly. And SVT has further subvarieties like AVRT, AVNRT, and these things. And for atrial flutter, that is also a supraventricular origin. And ventricular arrhythmia, that is mainly ventricular fibrillation and ventricular tachycardia. You can also remember it like this way. But clinically speaking, broad complex and narrow QRS complex, that is the main classification. Okay. So SVT patients usually refers to any tachycardia which is not ventricular in origin. Episodes are characterized by sudden onset of narrow complex tachycardia, typically atrioventricular nodal reentrant tachycardia or AVNRT. So normally we know that the electrical impulse goes from the SA node to AV node, and then it goes to the different, like right and left branches or bundle branches, and then go through the fiber, like Purkinje fibers. But if the accessory pathway is built within the AV node, then the re-entrance of the electrical impulse goes back again into the atrium. So that is known as the AVNRT. And other would be the atrioventricular re-entry tachycardia, AVRT, and some junctional tachycardia, which is basically spontaneous abnormal electrical conduction at the atrioventricular node. So these are actually different variants of the SVT. Management, we have, in case of a supraventricular tachycardia, this is not mentioned in the guideline, but in the cardiology training, we used to offer the patient with lots of cold water, because Valsalva maneuver, Valsalva maneuver, the similar effect can be achieved with giving cold water at the same time. So this is actually done in peripheral setting where we don't have much of the pharmacologic management. We usually go for Valsalva maneuver. We give the patient oxygen, give the patient lots of cold water to drink, which causes temporary vasoconstriction and helps in reduction in the cardiac output, and then we refer the patient to higher center. That is something we used to do back in our training. So vagal maneuver or Valsalva maneuver, that should be tried in the first place, or carotid sinus massage, that can also be tried at the same time. And then IV adenosine. IV adenosine 6 milligram. If it is not working, then we can give further loading dose 12 milligram. Not working, then give another further dose of 12 milligram. However, adenosine, this type of antiarrhythmic drugs, they have a very short action potential. So that's why these loading doses can be given repeatedly every 10 minutes afterwards. And it can cause, profuse bronchospasm at the same time, which is why in patients who have obstructive airway disease, such as asthma, COPD, adenosine is not given. So we can, in management of SVT, we can start with calcium channel blocker, verapamil initially. And final option is electrical cardioversion. Prevention of the episode, we can go for, beta blockers and radio frequency ablation. For example, if you think that this is an AVNRT or nodal reentry tachycardia, so there is definitely an accessory pathway within the AV node or the existing channel. So if we just ablate the abnormal pathway, then there will be no more, reentrance of the electrical pulses. So it will follow the normal pathway. So that is the main, this is done for prophylactic basis or, prevention basis. Radio frequency ablation can be achieved with the help of EPS study. Let's try to solve this question. 30-year-old woman is admitted to the emergency department following an acute onset of palpitation. Blood pressure is normal, pulse is tachycardia, 150 per minute, and ECG shows a narrow complex tachycardia. Intravenous access is gained and 6 milligram of adenosine is given with no effect. What is the most appropriate next step? IV adenosine 12 milligram, IV adenosine 6 milligram, radiofrequency ablation, electrical cardioversion, or IV verapamil 2.5 to 5 milligram. Which one is it? Anyone?
IV adenosine 12 milligram.
12 milligram, very good. Because we double the dose in the successive, steps. And electrical cardioversion should not be done because the pulse and the blood pressure is normal here. Especially the blood pressure is normal. So no need to go for DC shock yet. Radiofrequency ablation, it can be done for prophylactic or prevention basis later on. And if 6, 12, 12 is failed, in that case, we could have gone for IV verapamil. Okay. Okay. Question number 11, 111. 25-year-old woman is brought to the emergency department by a friend. She developed palpitations around 30 minutes ago whilst drinking a cup of coffee. Her only past medical history is of note asthma and menorrhagia, for which she uses a salbutamol inhaler and takes tranexamic acid respectively. The admission ECG shows supraventricular tachycardia at a rate of 160 beats per minute. Vagal maneuvers are unsuccessful. What is the most appropriate next step in the management? Is it IV verapamil, IV amiodarone, IV adenosine, electrical cardioversion, or IV esmolol? Which one?
IV verapamil, since she has asthma, adenosine can be given.
Yes, very good. Okay. So now we have like atrial fibrillation left. Let me just go through if I have missed any topics yet. No, so far I've covered most of these topics. So atrial fibrillation, this was, I think, the most important or only one arrhythmia that we used to go through in our MBBS curriculum, because in our MBBS curriculum, ventricular arrhythmias or SVTs, these were not that much, discussed. Only the atrial fibrillation was focused. And I remember that during in OSPI, because of my current job, I have to teach like medical undergrads a lot, especially the fifth-year students. So that's why I usually have to show them like the only 3 ECGs. One is the complete heart block, one is inferior MI, and the other one is the atrial fibrillation. So this is something that I like talking about. It's very, like student friendly as well as post-graduation and undergraduation friendly. And believe it or not, atrial fibrillation is actually the most common arrhythmia that we have to deal with every now and then. So it's a most common sustained cardiac arrhythmia, and 5% of the patients over age of 70 to 75 years, and 10% of the patients in 80 to 85 years. Atrial fibrillation, mainly it causes symptomatic palpitation, and in the long run, it can cause inefficient cardiac function. Probably the most important aspects of managing the patient. And also atrial fibrillation has a important complication, that is chances of thromboembolism. So that's why in most of the atrial fibrillation patient, we do a CHA2DS2-VAS scoring and consider whether we give the patient any antiplatelets or anticoagulant for prevention of thromboembolism. Types of atrial fibrillation, there are mainly 3 types. One is paroxysmal, the other one, then first detected episode, paroxysmal, and persistent or permanent. Previously, we had the 3 classification, that is paroxysmal, persistent, and permanent. Nowadays, persistent or permanent is in this one group, and paroxysmal in the second group, and the first detected episode, but there is no subsequent episode, that is in the another separate type of group. So first detected episode, irrespective of whether it is symptomatic or self-terminating, recurrent episodes, when a patient has 2 or more episodes of atrial fibrillation. And if the episodes of atrial fibrillation terminate spontaneously, then the term is known as paroxysmal. So in paroxysmal atrial fibrillation, we did not give the patient any sort of treatment. It just terminates spontaneously. That is known as the paroxysmal atrial fibrillation. This is actually the most common variant. And these episodes usually last less than 7 days. Like, for example, the patients will be complaining of, like fluttering of the heart or palpitations happening 1 or 2 times a day, but never lasting for more than 7 days. And if you ask them, like, how does it go away? They will say that it just goes away spontaneously. I don't take any medicine for it. That is the typical way a paroxysmal atrial fibrillation presents like. If the arrhythmia is not self-terminating, then the term is persistent. And if the episodes last generally more than 7 days. Permanent atrial fibrillation is there is continuous atrial fibrillation which cannot be cardioverted, or if attempts to do so are deemed inappropriate. One of the common causes of permanent atrial fibrillation is valvular heart disease. For example, a patient with mitral stenosis or atrial septal defect now develop atrial fibrillation. That will be permanent, okay? So you can replace the patient's, like a heart valve, but that will still not cause, restoration of the sinus rhythm. But, chances of further, progression, that will be definitely halted. And after the valve replacement, you have to give the patient, anticoagulants such as, like warfarin, so that stroke or, thromboembolic complications doesn't take place in the patient. But a rhythm that has been irregular, it will always be like that forever. So you can see in permanent atrial fibrillation, treatments are mainly rate control and anticoagulation, but rhythm control is never possible. So that's why it should not be done. Sign symptoms of atrial fibrillation, common sign symptoms are basically palpitation and syncope. Shortness of breath, chest pain, these are rare presentation. In the pulse examination, we get the irregular pulse. Okay, investigation is ECG, and thyroid function test. So if you just focus on the causes of atrial fibrillation, that will help you to go for the types of investigation. So basically anything and everything can cause atrial fibrillation. One of the we used to remember the causes of atrial fibrillation into cardiac and non-cardiac causes. So among the cardiac causes, common cause of atrial fibrillation would be hypertension, myocardial infarction, valvular heart disease, cardiomyopathies, so on. And from the non-cardiac causes, thyrotoxicosis and pheochromocytoma. So certain drugs that can also cause atrial fibrillation, pneumonia, very common cause for atrial fibrillation. Management, basically rate control, rhythm control, and reducing the stroke risk. This is the main management protocol. So for rate control, the medications that are used are BCD, that is the mnemonic. So BCD means B for beta blocker, C for calcium channel blocker, and D for digoxin. And for rhythm control, it can be either with electrical cardioversion or chemical cardioversion. Electrical cardioversion by the means of DC shock, and chemical cardioversion is done by the means of amiodarone or flecainide or any other antiarrhythmic. Commonly, amiodarone and flecainide, these are used for the management of atrial fibrillation. And for reducing stroke risk, we usually give DOACs or NOACs, that is direct oral anticoagulants or warfarin. All right. So patients with whom we should consider rate control and rhythm control. So factors favoring rate control strategy, if older patient and has a structural heart disease, in that case, we focus on the rate control strategy. And rhythm control strategy is considered when the patient is younger than 65 years of age, patient is symptomatic, first presentation of atrial fibrillation, lone atrial fibrillation or atrial fibrillation secondary to a corrected precipitant, for example, alcohol. And if the patient has congestive cardiac failure, in that case, we can opt for rhythm control. Otherwise, actually, no need to go for rhythm control. Rate control can be done with beta blocker or rate limiting calcium channel blocker as a first line to control the rate of heart failure, rate in atrial fibrillation. If one drug is not control the rate adequately, then combination therapy can be given, like either a combination of beta blocker and digoxin, or beta blocker with diltiazem, or diltiazem plus digoxin, or diltiazem plus beta blocker, something like that. But never the combination of all three drugs at the same time. That will cause profuse bradycardia and even myocardial depression and precipitating heart failure. Okay, rhythm control, for rhythm control purpose, if there is patient presence within less than 48 hours and has the factors favoring for the rhythm control, in that case, we can start off with an emergency electrical cardioversion followed by anticoagulation. And if we are going for, rhythm restoration strategy on an elective basis, in that case, we usually anticoagulate the patient for 4 weeks, and then we go for, a DC shock or, electrical cardioversion followed by another further 4 weeks of anticoagulation. And when considering cardioversion, it's very important to remember that the moment a patient switches from atrial fibrillation to sinus rhythm presents the highest risk of embolism. So that's why after cardioverting the patient back to the sinus rhythm, it's very important to start the patient with anticoagulants, because this time frame, when the irregular heartbeat goes back to the regular heart rhythm, that is the small period of time frame most responsible or significant time for causing stroke or other risks of embolism, because the thrombus is actually dislodged from the fibrillating atrium. That's why. All right. Cardioversion is done, electrical cardioversion as an emergency, if the patient is hemodynamically unstable. For that, I meant that adverse sign is present. That is, either patient is having any heart failure, MI, or syncope, or shock, cardiogenic shock. In that case, if the patient is hemodynamically unstable, go for emergency electrical cardioversion. And electrical or pharmacological, or pharmacological, basically another word for chemical cardioversion, can be considered as an elective procedure when rhythm control strategy is preferred. For example, patient is hemodynamically stable. Patient is, for example, 45 years of age, known to be alcoholic, and has concurrent heart failure features, or for example, has first time presented with atrial fibrillation. Now, in that case, we can definitely go for, like rhythm restoration. So in this patient, as the patient is hemodynamically stable, we do not have to go for electrical cardioversion right away. We can take some time, go for anticoagulation for 4 weeks, and then give the patient, like prepare fully for the electrical cardioversion, and then cardiovert the patient for restoration of the sinus rhythm. Okay. So if the onset of the atrial fibrillation is less than 48 hours, and patients should be heparinized, patients who have risk factors for ischemic stroke should be put out on lifelong oral anticoagulation. Otherwise, patient may be cardioverted using either electrical DC cardioversion or amiodarone. But flecainide can be given in patients who do not have any structural heart disease. If a patient has structural heart disease, such as ischemic heart disease or cardiomyopathy, in that case, you cannot give flecainide. In that case, choice of chemical cardioversion is amiodarone. There are some other agents that can also help in, cardioversion, but these are actually more used for rate control strategy, not for rhythm control strategy. For reducing stroke risk, that is, this is the CHADVA score that I was talking about. So this score is actually mainly done to consider in a patient with atrial fibrillation to give aspirin or warfarin. That's the main debate here. So for example, the C is for congestive cardiac failure, H is for hypertension, A is for age more than 75 years, D is for diabetes. So age more than 75 will be getting 2 score, but if the age is 65 to 74 years, that is score 1. D is for diabetes, that is score 1. S is for stroke or transient ischemic attack. S2 means point is 2. V is for vascular disease, including ischemic heart disease or peripheral arterial disease. A is for, this A is for the age 65 to 74 years. And S is for sex or female. CHADVAs. So this is basically the CHADVA score. If the age is more than 75, and if there is a patient having any features of stroke or transient ischemic attack currently or previously, that will be 2 score. Rest of the other parameters will be 1 score. And another S is for sex or female patients. Notice that this is not male patient. If the patient is female, in that case, score is 1. So there are lots of questions that will be coming from CHADVA scoring. I will try to ask these questions to you. So if the score is 0, then no treatment is required. If the score is 1, then male, go for anticoagulation. If it is female, then no treatment is required. If the score is 2 or more, in that case, offer anticoagulation. So anticoagulation can be either in the form of warfarin or DOACs. If this is a valvular heart disease, in that case, warfarin is preferred. But if this is a non-valvular heart disease, in that case, you can consider, dabigatran or rivaroxaban and all this, like newer oral anticoagulants. Okay. So following a stroke or transient ischemic attack, warfarin should be given as the anticoagulant of choice. Aspirin or dipyridamole should only be given if needed for the treatment of other comorbidities. And in acute stroke patients, in the absence of hemorrhage, anticoagulation therapy should be commenced after 2 weeks. If you give, like, for example, in an ischemic stroke patient, patient already was receiving, warfarin. In that case, within 2 weeks, you should not restart the warfarin because it will lead to hemorrhagic transformation. If imaging shows very large cerebral infarction, then the initiation of anticoagulation should be delayed because larger the infarction is, this is another type of discussion, but I will just like try to draw a diagram. For example, if you imagine in the brain, like this area of the stroke, okay, this is the infarct, and this perilesional area, okay, so this perilesional area is known as paraambla. So if the area of infarct is large, then the like perilesional ambra region will be larger. So in acutely, if you like go for anticoagulation like with warfarin in such patients, it will cause rapid like dissolution of the clot here, and there will be blood seeping and thereby increasing the chances of hemorrhagic transformation. So that's why you should never start with warfarin or DOACs or NOACs in acute stroke patient within 2 weeks. All right, now let's solve a few questions. 66-year-old lady presented to the emergency department with 5-minute history of right upper limb weakness, which spontaneously resolved. She had a past medical history of hypertension for which she is taking tablet amlodipine 10 milligram once daily. She is non-diabetic. She currently smokes 10 cigarettes a day. Her examination was remarkable for an irregular heartbeat. Electrocardiogram or ECG confirms the diagnosis of atrial fibrillation. CT scan shows no evidence of intracranial hemorrhage. She is otherwise well with a normal renal function. What is the most appropriate next step? Should you refer for anticoagulation clinic, start 300 milligram aspirin and discharge home? Non-urgent referral to the TIA clinic, commence the patient on anticoagulation, refer the patient to psychiatry. Which one? The patient has atrial fibrillation. Now the patient has presented with features of transient ischemic attack. Her Chadva score is obviously more than 2 or more than that. So what should the CT scan shows? There is no hemorrhagic stroke. So possibly there might be a possibility of any infarction. So ischemic stroke is a good big possibility here. So now what is the step or next step management here?
D.
Commence the patient on anticoagulation. Okay. All right. So the score did anybody did the score? This is 1 score, female patient 2. And then TIA, that is already 3, 4, 5, and hypertension is 6. So yes, we should start the patient with anticoagulation. Score is more than 2. Okay. So 17-year-old male is taken to the emergency department due to alcohol intoxication. On examination, he is noted to be tachycardic with a rate of 140 beats per minute. ECG shows atrial fibrillation. Following morning, he is noted to be in sinus rhythm. What is the most appropriate management? Sotalol and aspirin, sotalol and warfarin, discharge, amiodarone and aspirin, refer for accessory pathway ablation.
Discharge.
Yes, please.
He can be discharged.
Patient can be discharged. Okay, very good. Because you can see, although the factors are favoring for rhythm control, right? Or restoration of the sinus rhythm, but the patient does not have any persistent atrial fibrillation. Already, patient has gone back to the sinus rhythm, and there is a obvious precipitating factor here, alcohol intoxication. Now that the patient is stable, this the patient has no longer any atrial fibrillation. So in that case, you can just discharge the patient home. Okay, very good. Okay. 72-year-old man presents with lethargy and palpitation for past 4 to 5 days. On examination, his pulse is 123 beats per minute. Irregular, blood pressure is normal, and chest is clear. ECG confirms atrial fibrillation. So this is a 72-year-old man. Okay. So what is the most appropriate drug to control his heart rate? Is it amiodarone, bisoprolol, digoxin, amlodipine, flecainide? Which one is it?
Bisoprolol.
Bisoprolol. Okay, very good. Not this one.
Rhythm.
Yeah. 75-year-old woman brought to the emergency department by her family. She has been getting more short of breath over the last 6 weeks and says her energy levels are low. ECG on arrival shows atrial fibrillation at the rate of 114 beats per minute. Blood pressure is normal and chest X-ray is unremarkable. What is the appropriate drug to control her heart rate? Is it felodipine, amiodarone, digoxin, flecainide, bisoprolol? Which one is it?
Bisoprolol.
Bisoprolol. Okay, very good. Okay, 141. 57-year-old man presents to the ED with palpitations for the past 36 hours. He has no past history of note. There is no associated chest pain or shortness of breath. Clinical examination is unremarkable other than an irregular tachycardia. ECG shows atrial fibrillation at the rate of 126 beats per minute with no other changes. What is the most appropriate management here? First, think whether the patient requires any warfarin or not. If the patient does not need any warfarin, in that case, warfarin containing options can be deducted here. Age is less than 65 years. Palpitation for past 36 hours. So this is probably the first episode. No past history, no symptoms currently, except for the palpitation. Clinical examination is unremarkable, and ECG shows atrial fibrillation. In that case, which one would you consider? Onset is less than 48 hours. So you can heparinize the patient and, like go for sinus rhythm restoration, emergency cardioversion, right? So this is the question that goes in the favor of factors favoring the rhythm control strategy. Patient age, look at the patient's age, look at the patient's presentation. Patient is symptomatic and the patient has what was the other indication? Oh, the onset of the symptom is less than 48 hours. In that case, we can go for emergency electrical cardioversion with heparinization. So option C is the answer. Okay. 35-year-old female has paroxysmal atrial fibrillation, was successfully treated with DC cardioversion 1 week ago. She is now resultantly on warfarin. A subsequent post-cardioversion echo shows no structural abnormalities. How long should the warfarin be continued? 4 weeks. Okay. All right, 75-year-old woman admitted to the acute medical unit with pneumonia. Her past medical history, TIA 2 months previously. So female patient 75, already score is 2. No, actually score is more than 75. No, score is 2. TIA history, so score is more than 2. On initial assessment, ECG revealed atrial fibrillation with ventricular rate 103. She was treated with IV fluids and antibiotics. She improved significantly. 2 further ECG overnight revealed normal sinus rhythm. Following day, she was seemed medically fit for discharge. So actually for the atrial fibrillation here, the precipitating factor was pneumonia. What is the single most appropriate management option regarding her episode of atrial fibrillation? No follow-up required. Repeat ECG in 2 weeks, oral anticoagulation, aspirin, or 24-hour tape, and consider oral anticoagulation. What is the answer here?
Oral anticoagulation.
Oral anticoagulation, yes, very good. Because although there is a precipitating factor here, but patient has a Chadva score more than 2. So patient should be started with oral anticoagulation. Okay. Question 148. A 70-year-old man presented to the emergency department following a fall and head injury. This is the third time fall in the past 12 months. He has a background of persistent atrial fibrillation, type 2 diabetes, and Parkinson's disease. He's taking tablet apixaban 5 mg BD, bisoprolol 5 mg once daily, co-beneldopa 100 mg QDS, and metformin 1 gram BD. CT head reveals no acute findings. What is the most appropriate management regarding his anticoagulation? Should you consider to stop apixaban for now and optimize his Parkinson medication and consider restarting in 6 months? Should we switch to aspirin? Should we stop the anticoagulation? Should we stop the apixaban for now and optimize his Parkinson medication and consider starting warfarin in 6 months? Or should we continue apixaban? So recurrent fall is probably due to, like his Parkinson medication there is some problem going on. But we are not actually supposed to give the opinion on Parkinson management. We are supposed to give the management regarding the anticoagulation. Should he continue with the anticoagulation or should we consider stopping? There is basically no role in switching to aspirin. So we can exclude that option, right?
Consider starting warfarin in 6 months.
Continue Epic 7.
Continue with 7. Very good. Because his score is 2. In that case, if you stop in this patient apixaban, then there is more chances of stroke complication in this patient. So here you should not stop with the anticoagulation. Okay. All right. So dabigatran, this is actually an example of the direct oral anticoagulants. So mechanism of action for each of the anticoagulants are present in this box. So heparin activates the antithrombin 3. There are 2 forms available, low molecular weight heparin and unfractionated heparin. Low molecular weight heparin is preferred over the unfractionated heparin because its like plasma half-life is relatively short in comparison to the unfractionated one. And whenever the bleeding complications are actually less in comparison to the unfractionated, and it's easier to, if there is any bleeding related to low molecular weight heparin, then management is easier in comparison to the unfractionated heparin. Clopidogrel is a P2Y12 inhibitor. It's a type of antiplatelet agent. It just prevents platelet aggregation. Abciximab is a glycoprotein 2B3 receptor inhibitor. Abciximab is more commonly used in the management of MI patient, especially non-ST elevated MI patients. Dabigatran, this is dabigatran and rivaroxaban. Both of these are actually direct oral anticoagulants. Dabigatran works with the thrombin pathway, and rivaroxaban works on the activated factor 10 pathway. So it's a direct thrombin inhibitor. It's one of the drugs developed over the past 10 to 15 years as an alternative of warfarin, with the advantage that it does not require any regular monitoring. So any of the DOACs or NOACs, they do not require any regular monitoring. With warfarin, we have to always check for the INR level, right? But with the importance of this dabigatran or any other forms of DOAC is complication, side effect profiles are, like less in comparison to warfarin. These are usually non-teratogenic or less teratogenic, but they do have the renal complications are actually more common, particularly in the older DOAC generations. Still, these are better tolerated and less side effects in comparison to warfarin. Dabigatran is currently used for 2 main indications. Firstly, prophylaxis of venous thromboembolism. And secondly, prevention of stroke in patients with non-valvular atrial fibrillation. Hemorrhage is the major side effect, and doses should be reduced in chronic kidney disease. So renal impairment, that's another side effect of this. DOACs or NOACs. And it should not be prescribed if the creatinine clearance is less, or the EGFR is less than 30 ml per minute. Or in stage 4, stage 4-5 CKD patients, you should not prescribe with the dabigatran. Okay, atrial flutter, actually, it's a least important topic from the cardiac arrhythmia. It's a form of supraventricular tachycardia. It can be present as 2:1 variable block or 3:1 variable block and something like that. In the ECG, it usually has like a sawtooth pattern type of ECG. So underlying atrial rate is often around 300. In comparison to that, the ventricular rate is very bare minimum. And the ventricular of heart rate is dependent on the degree of the AV block. For example, if there is 2:1 block, then the ventricular rate will be half of the atrial rate. So if the atrial rate is 300, then in 2:1 block, the ventricular rate will be 150 per minute. Flutter waves may be visible following a carotid sinus massage or adenosine. Management is similar to that of the atrial fibrillation, although medication may be less effective. Atrial flutter is more sensitive to cardioversion. However, lower energy levels may be used, and radiofrequency ablation is mainly the treatment option. WPW syndrome, you have to know about the ECG features of the WPW syndrome. One of the ECG features is the short PR interval, widening of the QRS complex with a slurred upstroke, that is the delta wave, and right or left axis deviation. In the more common one is the left axis deviation variety, if there is right-sided accessory pathway. I will show you the delta wave because in my MRCP Part 2 exam, WPW syndrome ECG came. You can see here that this is basically the slurred upstroke of the QRS complex. So slurred upstroke of the QRS complex, this is known as the delta wave, wide QRS complex, and this is more than one large square, and short PR interval, that is, it is less than 120 millisecond. So these are mainly the WPW syndrome, like notifying ECG changes. Okay. So there are mainly two types, type A and type B. These are all theoretical. Just give it a read. For example, type A, this is the left-sided pathway. Left-sided pathway, dominant R wave in the V1, and type B is basically the right-sided. So the accessory pathway is on the right side. That is showing the left axis deviation. And association of WPW, this can be further associated with other forms of congenital or inherited cardiac abnormalities, such as it can be in association with HOCM, mitral valve prolapse, Epstein abnormality, and thyrotoxicosis. It's just random association. And ASD secondum variety. Treatment is radiofrequency ablation. Okay, so definitive treatment is you just have to cut the accessory pathway. That's it, with the help of radiofrequency ablation. And medical therapy, beta blockers, amiodarone and flecainide can be given. So there is a rare type of type C WPW where the delta waves are upright in lead V1 to V4, but negative leads in V5 to V6. Not important. Sotalol should be avoided if there is any coexistent atrial fibrillation, as the prolongation of the refractory period at the AV node may increase the rate of transmission through the accessory pathway. Thing is, in WPW, because of the accessory pathway, it kind of works in a very similar pattern like the AV NRT type of, like junctional arrhythmia. So in that case, if there is concomitant atrial fibrillation, for example, the patient has WPW at the same time atrial fibrillation, in that case, if you give beta blocker, that will actually prolong the refractory period. And if the refractory period is more, then more electrical impulses will be going through the accessory pathway. That will actually cause more symptoms or, palpitation to the patient, which is why if there is concomitant atrial fibrillation, then sotalol should be avoided. But this is a rare association, so only for the cardiologist. information. Okay. So you're working in the acute medicine, covering the hospital at night. You are called to the surgical ward to see a 35-year-old patient who's reporting palpitations. She is known to have WPW syndrome. Her ECG shows fast atrial fibrillation. On examination, there is no evidence of hemodynamic instability. So patient is hemodynamically stable. Most appropriate pharmacological management option for this patient. Should we go for adenosine? Should we go for verapamil? Should we go for metoprolol, digoxin, or flecainide? Which one?
Flecainide.
Flecainide. Okay, very good. Because there is no structural abnormality present and patient has fast atrial fibrillation. So we cannot go for metoprolol. If the patient had no atrial fibrillation, the first line management would be metoprolol. Basically, antiarrhythmic drugs, amiodarone or flecainide, these are given in WPW as a pharmacological intervention. Okay. Long QT, I have already covered this, especially you can see that QT interval, normal corrected QT interval is less than 430 millisecond in male and 450 millisecond in case of female. And causes are again, the causes behind polymorphic VT and the causes behind long QT will be the same. Because polymorphic VT is something that gets precipitated by the long QT. So these causes. Features are maybe picked up on the routine ECG following family screening. Long QT 1, 2, and 3, there are 3 varieties. In long QT1 syndrome, usually associated with exertional syncope, for example, after rigorous physical activity, like hitting the gym, swimming, that can act as a precipitating factor. For long QT2 variety, this is associated with syncope occurring following emotional stress, exercise, or auditory stimuli. And long QT3, that can happen even during rest or during sleeping. So you might be hearing some, like incidental, deaths, like the patient has died. He was so young, but he died during the sleep. I don't know what went wrong. So long QT is a possibility there. Sudden cardiac death can be the first presentation of long QT. Management is avoid drugs or avoid the precipitants. Beta blockers and implantable cardioverter defibrillators are the main management. Okay. You're considering prescribing an antibiotic to a 28-year-old man who tells you he has long QT syndrome. Which antibiotic is the most important to avoid? Is it doxycycline, trimethoprim, erythromycin, or rifampicin, coamoxiclav? Which one?
Erythromycin.
Erythromycin, very good. An elderly patient with a history of atrial fibrillation develops torsades de pointes shortly after being started on sotalol. So what effect does sotalol have on the cardiac cell membrane to make this more likely? Is it blockage of the sodium channel, opening of the potassium channel, blockage of the potassium channel, opening of the calcium channel, and opening of the sodium channel? Which one is it?
Potassium channel blocker.
Yeah, blockage of the potassium channel, because torsades de pointes, polymorphic VT, long QT, all of these are basically blockage of the potassium channel that results in, torsades de pointes or long QT. Mainly in the potassium efflux during the cardiac action potential, either in the phase 1 or phase 3. Okay, 84-year-old female with a background of osteoporosis is given an infusion of pamidronate. A week later, she presents to the GP complaining of paresthesia. On examination, she has hyperreflexia and carpopedal spasm. Given the electrolyte abnormality she is likely to have developed, what ECG abnormality is most associated with this? AV nodal block, delta wave, tented T wave, long QT, atrial flutter. Which one? Which electrical abnormality are they talking about?
Hypocalcemia. She has long QT syndrome.
Yes, very good. Hypocalcemia can cause long QT. Okay, can anyone mention in hypocalcemia, what are the 2 physical examinations that can be done, like a sign? This carpopedal spasm, this is known as the Trogius sign. And the other one, this is known as, if you tap over the facial nerve distribution, there will be twitching of the orofacial muscle. This is known as the Schwastek sign. Okay, not related to this, just wanted to mention. So here they're showing the normal QT interval. ECG, a 34-year-old women emergency department following a collapse. ECG shows polymorphic VT. Which one of the following is not associated with increased risk of developing torsitis de pointes? So which one is not associated? They want to know. Is it tricyclic antidepressant, subarachnoid hemorrhage, hypercalcemia, Romanov-Ward syndrome, or hypothermia? Which one is it?
Hypercalcemia.
Very good. Okay. Last one. Which one of the following drug is most likely to cause a prolongation of the QT interval? Metoclopramide, verapamil, ceftriaxone, sotalol, digoxin.
Sotalol.
Yes, this is the class 1 antiarrhythmic drug. It causes prolongation of the refractory period. Okay. So we are actually towards the very end of our session. Just a couple of topics are left. Implantable cardiac defibrillator. So there are basically some of the indications when we can consider ICD. ICDs are very much similar devices that looks like pacemaker. It is also given underneath the device is placed underneath the left, collarbone, underneath the subcutaneous area. And it has like 2 leads. One of the lead is actually given through the, one of the lead is facing towards the, apex, and the other lead is actually facing towards the, base of the heart. So indications are in long QT syndrome, we can give the patient ICDs. In any patient, like there are actually different types of indication, primary prevention and secondary prevention. And in secondary prevention, most common causes in a MI patient, if the patient was sustained any VT or VF or any malignant arrhythmia, 4 to 6 weeks after the MI management, we can consider elective, ICD insertion in those patients. And for primary prevention, usually patients who have like familial condition, in those cases, like long QT or ARVC, HOCM, in those patients, Brugada syndrome, we can go for ICDs. So here you can see long QT, hypertrophic obstructive cardiomyopathy, previous cardiac arrest due to VT or VF, that is the malignant ventricular arrhythmia, previous myocardial infarction with non-sustained VT on 24-hour monitoring, inducible VT on electrophysiological testing, and if the ejection fraction is less than 35%. This is one of the secondary prevention, secondary indication of implantable cardiac defibrillator and Brugada syndrome. In these cases, we can go for implantable cardiac defibrillator. Each one of the following is an indication for implantable cardiac defibrillator, except for which one is the answer? WPW. The problem is with the accessory pathway. So in WPW, we just ablate the radiofrequency ablation or beta blocker, but there is no need to go for implantable cardiac defibrillator here. The WPW is very less likely to be associated with ventricular arrhythmia. It will most likely cause SVT. So in SVT management, there is no indication of ICD. All right, so these are basically the cardiac arrhythmia management. I think one is not mentioned here, but then again, it's also technically mentioned within the cardiac arrest protocol. That is the bradycardia. So normally bradycardia, that can be a physiological phenomenon during sleep, during exercise, in among the athletes patients, or like heavy exercise. Yes, these are the, even pregnancy. Normally in pregnancy, we know that tachyarrhythmia takes place. Certain people taking drugs like beta blocker, calcium channel blocker, digoxin, bradycardia can take place. Apart from that, complete heart block, inferior MI, and degenerative disease, sick sinus syndrome. So these are the common causes of bradycardia. In bradycardia patients, again, we have to assess whether there is any adverse sign present or not, and whether the patient is symptomatic. Then if the treatment of the underlying cause, that is our main focus. So if there is any electrolyte imbalance, that should be corrected. If there is any drug that is causing the symptomatic bradycardia, that should be stopped. And if the patient goes into, like cardiac arrest due to bradycardia, in that case, what we have to do is, previously we used to treat the patient with atropine infusion, 300 mcg, bolus dose followed by every 3 to 5 minutes. But nowadays, this is not done. Usually we go straight for the adrenaline. If adrenaline is not available, isoprenaline can be given. And interim basis, we can go for, like transcutaneous pacing. And permanent basis, we can go for, like pacemaker insertion or transvenous pacing. So these are the actually modality of treatment for treating symptomatic bradycardia. Mainly for symptomatic bradycardia, ultimately treatment is pacemaker, dual chamber pacemaker. Okay. So for just to summarize our entire topics that we have read so far, we have discussed about ECG leads plus area of the heart that it represents plus coronary arteries, normal ECG variance. Causes of left axis and right axis deviation, causes of left bundle branch block. Okay, and we have discussed about the cardiac action potentials. We have discussed about different types of pulses. We have discussed about jugular venous pressure, JVP, mainly A wave, focus on the A wave and the V wave. Okay, among these pulses, different types of pathological variants, that is important, and causes behind those. And then heart sounds. Mainly S2 is very, very important. Like what are the causes of loud S2? What are the causes of soft S2? Causes of wide fixed splitting? What are the causes of splitting of the second heart sound? Reverse splitting of the second heart sound, that is more important. And changes of ECG in hypothermia. Okay. Causes of prolongation of PR interval. Causes of long QT syndrome, LQTS. In terms of arrhythmia, we have mentioned about the ACLS for cardiac arrest protocol. Number 2, we have discussed about peri-arrest tachycardia. Among that, broad QRS complex and narrow QRS complex tachycardia. Among that, we have mentioned VT, both monomorphic and polymorphic VT. In the narrow QRS complex, we have discussed about SVT and atrial fibrillation. So from atrial fibrillation, go through the rate control, the rhythm control strategy, plus anticoagulation, particularly the Chadba scoring. And some familial cardiac arrhythmia we have discussed also. Among that, catecholaminaergic polymorphic ventricular tachycardia, and some rare secondary arrhythmia, that is multifocal atrial tachycardia. And we have also discussed about WPW syndrome, and we have also discussed about the implantable cardioverter defibrillator. So this is basically the things we have discussed so far. So if any of you have any questions from the things we have discussed so far, you can ask me. Any questions? Actually, if you just, like start reading the cardiology, because if you're waiting for my lectures to be done and then you think that in 1 week you will go through the cardiology, then it might be a little bit difficult to pick up. So what you have to do is, if you're starting very new, like this is your first class, so at least go through the topics that I have covered today, at least the cardiac arrhythmia and the initial portion of the cardiology section, like from up until the point of JVP, till the infective endocarditis portion. So at least cover that from your lecture note. And if possible, then listen to the recording from the previous class and go through the ischemic heart disease and the heart failure. So then you will have most of the things of cardiology you would have covered by this time. And then start solving questions, at least 50 to 70 questions. And if then in the third class, you will see that a lot of things are actually making sense. So try to at least go through the topics that I have covered in my class, because that will actually help you to focus more in the successive or the next classes. After, if you're waiting for everything to get finished and then you will start, then it might be a little bit difficult, or you might already forget the things that were discussed. This is how the human minds or brain work. It's very normal. So you just adult learning, adult teaching, both of these things are very hard. It's very difficult to put concentration on study materials for more than 10 minutes. That happens to me. So that's why you can just come up with a routine by yourself. Try to, take baby steps and try to solve questions. If you're not solving questions, then you will not really find it interesting. Only reading is not going to help you. Like finish a topic, then solve questions, and then come back to the next topic, or whichever you find more convenient. So thank you all for the patient participation and the active participation. Hope to see you in the next class. Till then, take care. I'm concluding my session now.
Thank you, ma'am.
Thank you.
Thank you.